Down for Barbara. It's a drop open ammo. Oh, God.
Watch your step, please.
Good morning. I'm going to ask you to keep your voice up and speak into that microphone, all right?
Right here.
Yes. Turn you back to you.
Good morning.
Good morning.
Could you please tell the jurors your first and last name?
Rebecca Gelada.
And how do you spell?
Counseling psychology in 2013 from William James College in Newton. I worked in the mental health field as a clinician in various positions for a time. Then I went back to school. I've been an RN in Massachusetts since 2017. I got my MSN in 2019, at which time I became a licensed and credentialed psychiatric nurse practitioner.
And where is that? Here in Massachusetts?
Yes.
Are you licensed anywhere else?
No.
And so can you tell us a little bit about your work history?
Sure. I have worked in as a detox nurse at McLean. I have worked as a therapist in outpatient clinicians prior to becoming a nurse. I have worked in DMH respite facilities, and now I'm a nurse practitioner.
And when you were a therapist doing outpatient therapist, was that something you were doing on your own as a social worker, or were you associated with a practice?
It was part of my training after I got my master's in counseling in 2013. So I had a panel of patients, but I was under the supervision of a licensed provider. It was up towards getting my licensure.
And where do you currently work?
South Shore Health.
And how long have you worked for South Shore Health?
Since 2021.
And how did you come to work at South Shore Health? What was the role that you started?
I had been working sort of in general practice as a psychiatric nurse practitioner, but I was interested in working in women's mental health specifically. And at that point, I was getting training to become, more specialized in it. And when a job opportunity became available, I applied for it.
And what kind of training is that you were doing to be more specialized in women's health?
So Postpartum Support International is the certifying body so that somebody can become certified in perinatal mental health. I did the 2-day, well, actually it was a 2-day training plus a 3rd day specifically for the psychopharmacology track of it. And then I took a examination and passed the examination.
And so are you certified by the Postpartum Support International?
I am.
Now, as far as the South Shore Perinatal Behavioral Health Clinic, how did you become affiliated with that?
That was the job I applied to in 2021.
Okay. And so when you came to the clinic, who was running the clinic or who was the director?
Julie Paul.
And as far as the clinic itself, what is the clinic's, what's the patient base, or who does the clinic service?
So we specialize in working with women who are pregnant and postpartum up to 2 years after the birth of their most recent baby. We offer medication management. We have a clinician on staff to do counseling. We have a few nurses that work in our program. We work with moms for any range of psychiatric disorders, including addiction.
And when we talk about the range of psychiatric disorders in women who are postpartum, what are we talking about?
Postpartum depression, anxiety, postpartum psychosis, bipolar disorder, panic disorder, obsessive compulsive disorder.
And so you mentioned postpartum psychosis. Have you yourself had the experience of treating women with postpartum psychosis?
I have, yes.
And how many patients approximately over the course of the last 5 years?
Approximately 5.
And how about postpartum depression and postpartum anxiety?
Hundreds.
And in the range of services that the clinic offers and the work that you do you oftentimes collaborate with other community providers to offer additional referrals or services to patients if they need it?
We do.
And how about when somebody appears before you and you believe they need a higher level of care than what you can offer? Do you have relationships with hospitalization programs, or are you able to make referrals for people for those services?
Yes.
Is that pretty common practice?
Yes.
And you mentioned that one of the services or one of the things offered to patients at the clinic is medication management.
Yes.
Is that a big part of what you do as a psychiatric nurse practitioner?
It is.
And what kind of training do you receive in order to be a prescriber?
So in order to be a prescriber, it's part of my master's in nursing. So you take courses like in advanced pharmacology, advanced health assessment, pathophysiology. It's part of the coursework of my degree. And then you actually have to take a certification exam, and you have to pass the exam. You have to go on and get a DEA license, a Massachusetts controlled substance license. You have to go on and get your advanced practice registered nursing license. So it's education and certification and licensure.
And so you've done the education, you did the certification, and do you have all the licensures that you just described here in Massachusetts?
I do.
And you also mentioned part of the services of working with social workers in the clinic. And what do the social workers do?
They provide short-term counseling to patients, again, because we specialize in up to 2 years postpartum. They could be available to provide counseling during that phase.
And traditionally, postpartum period is a year after birth, right?
Correct.
So why does the clinic offer support for women up to 2 years?
We do acknowledge that while the highest risk period is the first 3 months postpartum, some women can struggle later on in the first year. They may have symptoms that emerge 9-10 months in. So we want to really be able to cover them and treat them if that happens and get them stable.
And does it sometimes take some time to get a person stable?
Absolutely.
And would that be why the program or your program goes up to 2 years?
Yes.
I want to draw your attention to a particular patient, Lindsay Clancy. You're familiar with that patient?
I am.
And how did you become involved with the care of Lindsay Clancy?
I became involved. She had initially seen Julie, and Julie was going to be leaving the clinic in December, and she wanted somebody to take care of Lindsay, again, longer term, since she would be leaving.
And at that time in 2022, when Julie was leaving, how many psychiatric nurse practitioners were at the clinic?
3.
And that includes Julie?
Yes.
And so who was the other nurse practitioner?
Andrea Warden.
And fair to say, you had a conversation with Julie about transferring care of this particular patient.
Yes.
And did you have more experience than the other nurse practitioner in the field, if you know?
Not necessarily.
But as far as taking Lindsay on as a patient, you were agreeable to taking over for Julie.
Yeah, in all likelihood, Andrea Warden only works 2 days at our clinic, so it could have been that I was working 5 days at that time, so I would have been more available.
So do you recall when the first contact you had with Lindsay Clancy, what date it was?
It was November 29th, 2022.
And so that was prior to Julie actually leaving, right?
Correct.
And fair to say, on that November 29th date, you had an actual follow-up with Lindsay.
I did.
Do you recall if it was virtual or was it in person?
I recall that it was virtual.
Okay. And in the practice of the clinic, is there an option for patients to do in-person or face-to-face
Yes.
in-person visits? And how does it come about that a person is either in person or virtual?
Our model is that we do initial assessments in person because new motherhood is very busy. There's a lot going on. We would rather see you than not. And so sometimes it is just easier to log on to a screen. Sometimes if we feel like someone would benefit from that face-to-face assessment, we'll say, please book your next appointment in person. And I know I did see Lindsay in person on at least one occasion, but my first was virtual.
And as far as kind of that choice about whether a patient appears virtual or in person is part of the calculus, the patient's choice, what they want to have happen.
Yeah.
And if there were circumstances where you believed or insisted that an in-person visit was required, would you articulate that to the patient?
Yes.
And then have them scheduled for an in-person?
Correct.
And as far as your first contact with Lindsay Clancy, were you aware that Julie Paul had done that initial intake with her in person?
I was.
And you had the chance to speak with Julie and to also review the records prior to meeting with her?
Correct.
And so were you aware that the day before, on November 28th, that Julie had some contact with Lindsay Clancy?
I was.
And that there was some phone interaction and there had been some messages sent to the clinic prior to you scheduling the meeting with her?
Correct, yes.
So would you agree that there was an issue that needed to be discussed and that led you to have this appointment with her prior to Julie actually leaving the program?
Yes.
When you met with Ms. Clancy, did you go through kind of a history of her presentation or present illness and kind of things that had occurred in the past?
I did.
And did you do kind of a nuts and bolts start to finish, or did you rely on some of the previous information she had disclosed?
I relied on some of the previous information she had disclosed, things like where she grew up, where she went to school, past clinical history, medication trials, but otherwise I would add my own clinical assessment.
Okay. And you were aware that in the history she presented to the clinic that she had previously been on some medications from another provider?
Correct, yes.
And that she started with Zoloft and Ativan and Benadryl?
Yes.
And that at some point she had visited the South Shore Hospital emergency room?
I believe it was November 16th.
And as a clinic that's associated with the South Shore Health System, do you have access to those records to review when you're dealing with a patient?
I do, yeah.
And so you're aware that when she went to the ER on November 16th, that they prescribed her trazodone?
I am.
And that she was reporting significant sleep issues at that time?
I was aware.
And then as far as the course of treatment at the clinic, were you able to review her course of treatment with Julie?
I was.
And fair to say that had been very recent, correct?
Very recent, yes.
Her first contact with the clinic was actually November 20th, correct?
Correct.
So you were aware that Julie had originally prescribed Prozac and had already changed the medication plan?
Yes, I was aware.
So in this meeting on November 29th, what was Lindsay reporting to you as the issues?
Would I be able to refer to my note, Your Honor?
Sure,
I'll
you
ju-
can.
I know most of it by memory, but just. So she had been taking mirtazapine, Remeron, at that point for 4 nights. So I believe she started it on November 25th. I was then seeing her on November 29th. She wasn't yet appreciating much difference for mood, anxiety, or insomnia. She would say, you know, I'm able to fall asleep for 2 hours, then I'm up for 3 hours in the middle of the night. And finding herself like in those 3 hours needing to take an Ativan to help her fall back asleep.
Now, when she said not appreciating much difference after taking it for 4 nights, in your training experience, is that something that you would normally see with that type of medication?
Yes, I wasn't surprised by that.
And for something like mirtazapine, or what's referred to as Remeron, right?
Remeron, yeah.
What class of drug is that?
It is a noradrenergic specific serotonin antidepressant. So it's slightly different than an SSRI. It does work on serotonin. It also works on the noradrenergic part is alpha receptors, which is what those are the receptors that our body responds to adrenaline. So it should help kind of calm you down. And it also works on histamine receptors, which is why it can make people sleepy.
So for Remeron, the fact that it has a calming effect on somebody with anxiety, it's sometimes a good fit, right?
Correct, yep.
And for somebody who might be complaining of sleep issues, it also has that secondary component that could help.
Yeah, it is a good choice for somebody who's having depression with prominent anxiety, insomnia, decreased appetite, because it can also increase appetite, which sometimes we want to happen.
And based on your view of her course of treatment with the clinic, those were issues that had arisen, right?
Mm-hmm. Yeah, I had noticed she had lost weight when she had gone to her PCP on October 20th. I believe she weighed like 130 pounds. On the 16th, when she went to the ED, she weighed 124 pounds, and they had done a pretty good medical workup on her with labs and everything. And she had reported like decreased appetite. So that was part of the clinical picture. And of course, not sleeping and very anxious.
Okay, and so with a medication like Remeron or mirtazapine, does it take time to work or to see results?
Yes.
And typically, what's the time frame for that drug?
I usually tell patients 4 to 6 weeks at a given dose is really going to give us a good idea of what that dose is going to do. You may start to see improvements in the first 2 weeks, but full clinical benefit can take a month, sometimes 8 weeks even.
And you were aware prior to her coming to this follow-up appointment with you that she had been reporting after taking the Remeron, feeling disoriented, forgetful, not feeling connected to the body, and anxious about whether she would actually sleep.
Correct.
And so were you aware that on November 28th that one of the nurses actually advised her to increase the Remeron?
I was.
And in addition to the medication, there was also the recommendation that she add some cognitive behavioral therapy to her treatment plan.
Yes.
And at that point on November 29th, by November 29th, were you aware of whether she had met with the social worker at the clinic?
She had not.
So did you have any indication that she had been engaging in some sort of cognitive behavioral or psychotherapy?
No.
Now, in relation to the medication piece of this follow-up, did you have any conversations with her about the concerns with the Remeron and what to do about that?
Yes, I did. I explained to her that it takes time to work, that it has only been 4 days. So I did encourage her to give it some more time. I also made additional recommendations as well.
Okay, and so what were the recommendations for?
I had known that Julie had tried like 5 milligrams of Ambien. So I had suggested maybe we could try 10, maybe we could try Ambien controlled release formulation, because she was having these wake ups in the middle of the night. The controlled release, kind of like the outer layer gives you 60% of the dose, helps you sleep. Then throughout the night, the inner layer gives you 40% of the dose, keeps you asleep. I said that might be a good option while we're waiting for the Remron to work. Because I was sort of thinking that maybe the underlying depression anxiety was causing the poor sleep. So while we're treating that, let's try these alternatives.
Okay. And so was she receptive to the Ambien?
No.
And did she say why?
No, I don't recall.
Did she express to you that she had some other concerns about taking certain types of medications for sleep, like benzodiazepines?
She did.
What did she say about that?
Was concerned about taking benzos. She had mentioned something called rebound anxiety. And what that is once the dose sort of wears off, your anxiety goes like above your baseline once the dose of a benzodiazepine wears off. It usually typically has to do with half-life of a medication. So for Ativan, that's usually between 8 and 24 hours. So if she's taking it in the middle of the night, the next morning she would feel more anxious. She was concerned about that. She also feels she was concerned about getting physically dependent on it because she had needed to take it for a number of nights.
And when she used the term rebound anxiety, was that her terminology?
Yes, it was.
And is that a terminology that you generally use in psychiatric care to describe that, what you just told us about?
Yeah, it's a clinical term.
And was that something that she mentioned first, or did you mention?
I put it in quotes in my notes, so that's usually when a patient mentions it, I put it in quotes.
Okay. And so as far as the plan to address the sleep and to help her with this complaint, with Ambien not a choice, what was your next recommendation?
I discussed hydroxyzine because it's an as-needed medication for anxiety, but it's not a benzodiazepine, doesn't really carry that risk of rebound anxiety or tolerance or dependence, and it could help her sleep. So I offered that as an alternative as well.
Were you aware that she was offered hydroxyzine before?
I was not aware of that.
Was she willing to try the hydroxyzine?
No.
And so what was her preference?
Her preference was to continue with the mirtazapine, the Remron 15 milligrams, and with the as-needed lorazepam.
And just so we kind of stay with the same terminology, when you're talking lorazepam.
Sorry, Ativan? Yeah.
Okay. And that was something that she expressed to you?
Yes.
Now, when you're dealing with a patient, and obviously this is your first interaction with her, right? Mm-hmm. Do you take into account your contact and communication with them in assessing whether they have the ability to make these choices or make informed decisions?
Absolutely.
And so your conversation with her about her medication treatment that she had received and what you were proposing as a plan, was she able to engage with you in that conversation?
Yep.
And so
it was collaborative.
And so when she declined the options that you first offered, mm-hmm. did you then present her with alternatives?
I did.
And ultimately, at the end of the day, whose choice is it as to what medication regimen person would be on?
The patient.
And why is that?
Because they have autonomy in their decisions. I'm only making recommendations based on my education, experience, training, what I'm seeing in terms of symptoms. The patient has the autonomy.
Are there instances where you're dealing with a patient where you have concerns that they shouldn't have autonomy? Or that, maybe if I rephrase that question, are there instances where you're dealing with a patient where you're concerned that they don't have the ability to make the right choice for themselves?
There would be, yeah.
And what options do you have in those instances?
In those instances, I mean, that sort of comes down to like competency, capacity to make decisions. Sometimes we might get our legal or ethics team involved to make a determination about whether this patient needs like a healthcare proxy to make their decisions, things like that.
And what about if a person presents with a very serious risk to their own physical health or the health of others? What are your options then?
I guess it would depend, if they had capacity to make their decisions.
In your interaction with her on November 29th, did you also go through with her and perform a mental screening test or a mental status screening?
I did.
And why do you do that?
It gives me some objective data of how the patient presents, like how is their speech, how's their appearance, what is their thought process, what's their thought content, things of that nature.
And in this meeting on November 29th of 2022, did you observe anything in which she displayed manic symptoms?
No.
And what traditionally are manic symptoms that you look for?
So there's a new mnemonic called DIGFAST. Try to do this quick. D is distractibility. Patient is highly distracted to lots of extraneous stimuli. There is pressured speech, grandiosity. So suddenly someone's like, I'm going to run for office. I'm going to be the president. And you're like, okay, you've never had an interest in that before. Sleep is really poor. So somebody might get 2 hours of sleep, but be like, go, 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 go. Increased goal-directed activity. So somebody might be painting the exterior of their house, painting the interior of their house. They might be, doing a bunch of different projects with no decompression time or feeling tired. Those are the general symptoms of mania. Sometimes there can be psychosis associated with it as well.
Okay. And so when you say mania and psychosis, are those two different things?
Yes.
And so are you also looking in these screenings to identify signs of psychosis?
Absolutely.
And what would be signs of psychosis usually?
Signs of psychosis, they can be sort of subtle. It might look like somebody's responding to, stimuli in their head, based on the way that their eyes are kind of tracking and they're not really paying attention. They may be quite guarded. They may have a delusional thought process. For example, they might think that somebody's out to get them when there's really no basis.
When you say responding to internal stimuli, is that generally when a person hears things, auditory hallucinations,
Yes.
or sees things that aren't there,
Correct.
visual hallucinations?
Mm-hmm.
And in addition to kind of watching for these things in your interaction, do you flat out ask somebody if they're experiencing those symptoms?
I do.
And in this first interaction that you had with Lindsay Clancy on 11/29, did she display any psychotic symptoms?
No.
What about assessing for suicidality? Do you do that as
I do.
well?
Mm-hmm.
And what do you do for that?
I generally ask, are you having any thoughts of wanting to hurt yourself or anybody else? And if the answer is yes, it sort of becomes a more in-depth assessment.
Do you go back and ask them about past thoughts?
Yes.
Whether they've articulated that?
Mm-hmm.
And in this case with Ms. Clancy, did she ever indicate whether she had a history of having suicidal thoughts or suicidal ideation?
She did not.
And how about homicidal ideation? Do you ask about that?
I do.
And in this instance, did she indicate whether she had any homicidal ideation or thoughts of harming other people?
No.
And as far as your observations of her presentation, like her mood and physically how she presented, did anything stand out to you as far as any of that?
She seemed anxious.
Okay.
Can I remember?
Okay, so as far as mood,
So I couldn't hear that.
Sorry, if you can finish your answer.
Sure. You done with that?
Yeah, I'm done.
Okay. All right.
so as far as mood, you noted her to be anxious, right?
Yes.
And you also look at a person's affect.
Mm-hmm.
And
You're gonna have to answer yes or no.
Yes. Sorry.
You observed her affect to be consistent with her mood, which you identified as anxious, right?
Mm-hmm.
And you examined somebody for
Yes.
their
Sorry.
thought process, right?
Right.
And what did you observe her thought process to be?
I observed her thought process to be linear, meaning you could follow it, her train of thought easily, and goal directed. She understood that she was there to be assessed for treatment, seemed to be her goal.
And do you also perform other screenings like the generalized anxiety depression scale and the Edinburgh scale?
I do.
And did you do that for Lindsay Clancy on November 29th?
I did.
And what were the results of those screens?
Her Edinburgh, so the Edinburgh scale is out of 30. She was 17.
What does that mean?
Moderate to severe symptoms, postpartum depression.
Now, with that particular screening tool that you can use, is it fair to say that with postpartum women, it often fluctuates?
It can. The patient is asked about the previous 7 days.
And as far as the generalized anxiety depression scale, what were the results of that screen?
May I look? 14 out of a total of 21.
And so what does that mean?
That would mean moderately severe anxiety.
And do you recall about how much or how long your interaction with her was on this telehealth visit?
It would have been 30 minutes.
And as a result of your interaction with her, did you come up with a plan moving forward as to what to do to address her issues or her concerns?
Yes.
What was the plan?
Continue Remeron 15 milligrams nightly, Ativan as needed. Those medications had been prescribed to her already. I did not write her any prescriptions at that visit.
And again, you indicated that you kind of encouraged her to stick with the Remeron and give it a chance to work.
Yes.
Was she receptive to doing that?
Yes.
And as far as, again, the sleep issue, based on your conversation with her and her request to continue with the Ativan, that's what you recommended?
Yes.
Did you also recommend other types of treatment that were not pharmacological?
Yes.
And what were those?
I recommended therapy, mindfulness, physical activity, meditation.
And you're aware that in the past she had reported physical activity was something that had been helpful to her?
Yes, I believe with her postpartum period with Dawson, her middle child, she had some anxiety, but it seemed to resolve with exercise in particular.
And fair to say, as it pertains to that experience, her postpartum with Dawson, she had reported at some point to the clinic that she had sought medication after having Dawson and that she didn't end up taking that medication, right?
Correct.
Now, after this particular follow-up, what's your practice when you're dealing with a patient to have them have an intervention if they need to get in touch with you or they have concerns before your next scheduled meeting?
I generally advise for non-emergencies, you can message me on the Epic portal.
Is that generally referred to as My Chart?
My chart, yeah.
And so My Chart, you could kind of go back and forth with messages, right?
Yes.
Did you encourage Lindsay to utilize My Chart if she felt the need to reach out to you before your next scheduled appointment?
Yes.
And at the end of that meeting, what was the plan for the next scheduled appointment? What was the track that you would ask her to be on as far as regular visits?
1 week.
And is that typical, 1 week?
1 to 2 weeks would be typical for a new patient.
And based on her report of symptoms or potential symptoms, was it important to you to identify if there were any changes?
Absolutely.
Now, were you aware by the time that meeting was completed that she did have an appointment scheduled with the social worker at your clinic, Letitia Dukes, for December 2nd?
I was aware of that, yes.
Now, after this meeting, so this was approximately 10:30 in the morning on 11/29, right?
Yes,
Did you have communication or contact with Lindsay Clancy on November 30th?
I did.
How did you have contact with her on that day?
She messaged me on the MyChart portal.
And you're aware that on that particular morning, Julie had informed her that she was leaving?
Yes.
Or were you aware, I should say?
Yes.
Now, when Lindsay messaged you, that was at 11 a.m. That was the first message, correct?
I would have to look at the note for the time.
Okay. Do you have those?
I do have the messages. I believe that'll be accurate. It was 11 a.m. Yep.
And did she ask you something specific in that message?
She did.
What did she ask you?
She asked me if it would be safe to stop taking Remeron after 5 nights.
So you had just met with her on November 29th.
Correct.
And talked about stopping Remeron, or talked about the concerns with Remeron.
We talked about continuing it on the 29th, yes.
But as far as the starting of that meeting, or where you were talking with her about the medication, she had already reported concerns with that medication, right?
Yes.
And so you encouraged her to stick with it.
Mhm.
And then the next day, she's asking to stop again.
Yes.
Do you recall that in that message, she indicated that in the course of that night, that the depression, she felt like the depression was much, much worse and not helping her sleep, and that she only got 2 hours?
Yes.
And she asked for a phone call from you, right?
Yes.
And did you call her back or did you message her back?
I messaged her back, but I also believe I had my nurse call her back because I was in between patients.
Okay. And so when you messaged her back, what did you ask her about to address that concern about stopping the Remeron after 5 nights?
I asked her what symptoms of depression did she notice was worsening.
And why did you do that?
Because she had mentioned that she felt that she was more depressed. She was attributing it to the medication.
But in her original message, did she give you any detail about what was worse?
Yeah, no, she did not. Sorry.
Is it important to you to know what symptoms are worse so that you know how to advise the patient?
Absolutely.
And did you again express to her a concern with stopping that particular medication after the short period of time she had been on it?
Yes, I shared with her that from what I understood, there had been really short medication trials since October, a short course of the Zoloft, a short course of Trazodone, and now what would be a short course of the Remeron. And I reiterated that sometimes it can take 4 to 6 weeks before these treatments start to work.
And you also knew from Julie Paul that she had only taken Prozac for approximately 4 days.
Correct.
So even though you gave her that information and encouraged her to stay with it, did you suggest an alternative?
I did.
And why did you suggest an alternative?
At this point, I'm trying to establish a therapeutic relationship with her as a patient. So I had met with her on the 29th. She's concerned about the mirtazapine. I'm kind of asking her to hang with me on it and give it a chance. But then the next day she's asking me again that she really doesn't like it. So at this point, I'm trying to kind of give her an alternative to establish a collaborative therapeutic relationship.
And at the end of the day, if you prescribe a medication and the patient doesn't want to take it,
Right.
You don't know if they're going to take it, right?
Exactly.
So what was the alternative you suggested?
I had suggested Prozac again, just because I had known that she had taken it in like 2012 whenever she was in nursing school, and she was able to take it for a year and she tolerated it okay. So I was kind of thinking maybe we could try to get you to retrial it. and it would be helpful.
And in making that recommendation to potentially restart it, had you reviewed the notes from Julie Paul in which the defendant, or Lindsay Clancy, indicated that when she took the Prozac, she felt disconnected, and that she was concerned about that, and that Julie had told her to stop it.
Mm-hmm. Yes.
But you still felt that it was worth giving it another try?
Mm-hmm.
And did you suggest anything else to pair with the Prozac to help sleep?
I did.
What did you suggest?
I recommended Seroquel, 25 milligrams.
And now Seroquel, is that a drug that you're familiar with?
I am.
And in your practice, especially dealing with women's health, perinatal issues, what would a low dose of Seroquel accomplish for a woman postpartum?
To get them to sleep.
And you are aware that Seroquel at higher doses could be used to treat other types of mental illnesses?
Yes.
But in this circumstance and with this recommendation, what was the purpose of the Seroquel?
So at this stage, my awareness was that she had tried a first-line option, which would be the benzodiazepine. The second-line options are usually what we call the sedating antidepressants, like trazodone, Remeron. So this would be more like a third-line option to try.
And is that because trazodone, she reported, didn't help her?
Didn't help.
And she didn't like the feeling on Remeron?
Right.
And so ultimately in that message, you kind of reiterated what your overall recommendations were, right?
Yes.
And it was to continue with the Remeron for another 10 days,
Mm-hmm.
and that the alternative would be to restart Prozac and add the 25 milligrams of Seroquel nightly for anxiety and insomnia. Is that
Yes.
correct?
Yes.
And so were you recommending that she be on all of those at the same time? That she do the Remeron, the Seroquel, the Prozac?
Yes.
And in your experience in psychiatric care and prescribing medication, is it a common practice to pair low doses or doses of particular types of medications together to effectively manage a person's symptoms?
Mm-hmm. At this clinical juncture, my thought was the combination of Remeron with the Prozac to treat the depression with prominent anxiety, the Seroquel to help alleviate the sleep.
And you're also addressing the concern of benzodiazepine dependency, right?
Correct.
Did you encourage her to do something to help you to kind of manage her treatment track going forward?
Yes.
What did you encourage her to do?
I had noticed that Lindsay was attributing a lot of her symptoms to her medication. And so I attached to the MyChart message 2 different mood charts. And what those one is daily, one is weekly. What it is it asks the patient each day to rate their mood from like 0 to 3. Good mood, bad mood, normal mood. It asks about like, did you take your medications? What doses? What were they? Check the box. How many hours a night did you sleep? What's your anxiety level? What's irritability? And what I wanted from that was, because it had all those parameters about mood and then also the medication, did you take it? We'd be able to track over time what the progression was. Was it getting worse since we started the medication? Was it actually getting better? I just wanted more data.
And were you aware that she was actually tracking those things herself?
No.
Now, you continued to have some back and forth messages with her throughout the course of the day on November 30th, correct?
Correct.
So we have, she reached out to you at 11.
Mm-hmm.
You responded to her at 11:52.
Yes.
There's another message from her at 12:15, right?
Yes.
And just going back for a second, when you were asking her about worsening symptoms, did you ask specifically about suicidal symptoms?
I did.
And why those, if she was expressing some depression and sleep issues?
Suicidal thoughts can can be a symptom of depression. And I just wanted to make sure I assessed that one because of its severity.
And is that something that's important to do before you make a recommendation to change a medication?
Yes.
Now, when she responded at 12:15, did she tell you anything about the suicidal thoughts or if she was having any?
She said she's not at the point of being suicidal.
Okay. She also indicated, but I'm really feeling as if I can't go on like this, right?
Right.
And she asked you to call in the Seroquel.
She did ask me to call in the Seroquel, yes.
So based on her response, did you feel that she was taking the alternative that you were offering?
Yes.
And then at 12:29 p.m., you get another message from her where she asks for a phone call, right?
Yes.
And again, at that point, did you have a phone call with her? Or did you continue to interact with her on the MyChart portal?
I interacted with her on the MyChart between patients, and I had my nurse give her a call.
And again, you said in between patients. So did you have the opportunity to pick up the phone and call?
I did not.
And is that one of the benefits of the messaging portal, that you can get back to somebody quicker?
Yes.
So when, before you were able to respond, did she send you some additional messages on MyChart, if you remember? Or if you could look at your notes.
Okay. I see that the symptoms of depression that she reported.
Yep. So just drawing your attention to 12:58 p.m.
Yes.
You get another message from her where she says, the symptoms of depression that are much worse are just feeling completely hopeless and unmotivated to do anything at all. And that she says, I printed the daily mood chart and we'll start it. Now, you said that you did ask your nurse to give her a phone call at some point, and so you're aware that a nurse did call her on November 30th at approximately 3:10 p.m.
Yes.
And during that phone call that Lindsay agreed to the plan and that she was going to pick up the Seroquel.
Yes.
Now, at that point, you had another meeting scheduled with her for a week out, right?
Mm-hmm.
But
yes.
Prior to that, did you also continue to communicate with her via MyChart?
Yes.
So moving into December 1st, again, were you able to send her a message?
She sent me a message on December 1st, and I did reply to it.
Okay, so December 1st at 12:20 p.m., we have a message from Lindsay Clancy. Hi, Rebecca. I really don't like the way I feel on the Remeron, and I know that I can't stick with it, or I can't stick with taking it. I started having very intrusive thoughts that I never had before. I didn't take it last night. I would really like to go back to Julie's original plan of Prozac in the morning and using Ativan and Benadryl at night as a Band-Aid until I get to a therapeutic level of Prozac. Please let me know if you agree with this plan. I know that I need to give it a good couple of weeks to work. Is that the message that you first received on December 1st?
It was.
And were you aware that that same day that Lindsay had reached out to her primary care physician asking for an immediate appointment with her nurse practitioner?
I was.
And that she was looking to discuss medications?
Yes.
Do you know if she actually got an appointment or went to the appointment there?
They had reached out to her, and she did not respond to their voicemails or MyChart messages, so she did not see them that day, to my knowledge.
So you're able to review the notes from the network of South Shore Health, right?
Correct, yes.
So you were able to review that she asked for an emergency appointment. They were able to find her an emergency appointment, but she didn't get back in enough time to actually get there.
Correct.
And so in the meantime, you're having a back and forth with her during the course of that day, December 1st.
Yes.
When she indicated to you in this message on December 1st about having intrusive thoughts and not liking the Remeron and not taking it, what was your response?
I sent her a detailed message of signs and symptoms of postpartum depression and anxiety, including factors like onset, risk factors, predictors, common symptoms, and it highlighted how intrusive thoughts are quite common in postpartum depression and anxiety. And I asked her, I'm wondering if that's what's going on here. I then asked her if she was able to take the Seroquel that night and if she noticed any improvement in terms of sleep or anxiety with the Seroquel.
Now, by giving her this information about postpartum depression and postpartum anxiety, was that consistent with a diagnosis that either you or Julie had given her in coming into the clinic?
Yes, we were thinking this could be some postpartum anxiety, and I wanted to familiarize her with the symptoms so that she had them written down and she could report them to me and understand that they are part of these disorders.
Okay. And you also gave her some information about obsessions and compulsions, right?
Mm-hmm.
And you said you asked her about the Seroquel and asked about sleep, right?
Yes.
And did you also reiterate that you were still encouraging to keep up with the Remeron for a period of time?
Yes.
And you further indicated to her that you wanted to kind of see if there was a correlation between the symptoms and the medication and that you just didn't have enough data.
Right.
In response to that message, she actually responded at 2:36 on December 1st, correct?
Yes.
And she indicated, thank you for the information. It was helpful. That she says, I panicked last night and just took Ativan and Benadryl, but tonight I'll stick with the plan and try the 15 of Remeron and the 25 of Seroquel. Do you recall if you had ever had a conversation with her about kind of using Ativan and Benadryl as a backup, or if she just felt like she wasn't getting any relief?
I recall having a conversation about using the Ativan as a backup. I believe it was, yes, in my initial, I said continue the Remeron and the Ativan as needed.
Okay.
Yeah.
And what about the Benadryl?
The Benadryl, I don't recall discussing.
But you were aware that she had reported the combination of Ativan and Benadryl had worked for her before.
Right.
And in that message, she also says, I'm sorry for all the messages. It's just a scary, very scary, stressful time for me. And starting new meds with side effects is very scary to me. I'll check in the morning and let you know how it went, right?
Right.
Okay. And again, you continued to have some contact with her on that same day after that.
I believe I responded to that, reassuring her that it's understandable to have fears, concerns about starting medications. And I sent her a detailed description of common question and answers I get from patients about medications, things like what to expect, how long does it take to work, what are common side effects, risks for, is there any risk for suicide, homicide with medications,
So in providing all this information with her, what were you trying to do?
Provide information because she had said it was so scary starting medication. So I wanted her to be equipped with understanding and, what to expect possibly.
And based on your interactions with her and your review of Julie Paul's interactions with her, this was a person that was very receptive to taking information, right?
Yes.
And as her role as a nurse, she was not afraid to ask questions. Is that fair to say?
No. Yes. She was not afraid.
And one of the things that you provided her, or the information you provided her in this detailed response back to her on December 1st at 3:04, was that there are other sources or resources that she could utilize that are available at the clinic, right?
Yes.
And
go ahead.
These two books, Exhibit 148.
Yep.
Good Moms Have Scary Thoughts, and this one, the Pregnancy Postpartum Anxiety Workbook.
Yes. Yes, I instructed her that we had copies of these books that we were giving out to patients and that she should come grab them when she was in clinic. And she informed me she would be seeing Letitia the next day for counseling, so she would grab them when she was there.
Okay. And so that day, December 1st, fair to say you went back and forth with her from about 12:30 to her last message, she was at 4:37 that day.
Yes.
And you said that she indicated that she did have an appointment the next day with Letitia Dukes.
Yes.
And were you aware of whether that was an in-person meeting?
Yes, it was in person because she said, I'll be in clinic, I'll be able to get those resources.
Okay. So moving to December 2nd, you didn't have a scheduled appointment with her, correct?
I did not.
And you knew she was going to see Letitia that morning in clinic, right?
Correct.
And you received several messages from her that morning.
I did.
Again, through the MyChart portal?
Yes.
Beginning at 7:51 a.m., where she sends you a message saying, "Hi, Rebecca. I took the 15 Remeron and 25 Seroquel. I woke up at 12 with horribly intrusive thoughts of wanting it to be all over. I took 1 milligram Ativan and went back to sleep, and the thoughts went away. Now that I have the Ativan on board, I really need to explore the option that I'm addicted to Ativan. I have a therapy appointment with Letitia in your office. I would really like to speak with someone in the substance use clinic to explore the option." Do you recall getting that message?
I do.
And did you respond to that message?
I did. I am credentialed at Cellshare Health and Addiction Medicine, so I felt that I could be that person to discuss those concerns with her.
Just discuss the substance use
Yes.
concerns?
Mm-hmm.
And so, and you're aware that the social workers can also screen for those as well.
Yes.
So at 8:51 on December 2nd, you respond to her, right?
I did.
And what do you tell her about the concern she just expressed in her 7:51 message?
I fully appreciate and understand the concern for benzo tolerance. It's not something I want to happen to my patients ever. That being said, there's a place for benzodiazepines, especially at the beginning and acute phase of treatment and getting someone stable. And then we would always pull back slowly. I think another thing to try tonight would be to take 50 milligrams of Seroquel, the 2 tablets, and see if that works better. The intrusive thoughts are part of postpartum depression, anxiety, very painful to think and experience, but I want to reassure you that it's not uncommon and mean nothing about who you are as a mother. Let me know what you think.
And so the recommendation from 25 to 50 milligrams of Seroquel, is that still within the range for treatment for insomnia?
Yes.
So would you characterize that as a low dose, a high dose?
A low dose.
And as far as her statement about intrusive thoughts, fair to say your response doesn't ask her more specifics about those thoughts, right?
No.
But you reiterate to her, just as you had in the lengthy messages where you provided information, that intrusive thoughts are pretty common.
Correct.
Now, did she respond to that message?
She did.
And so at 9:04 on December 2nd, there's a response from Lindsay Clancy. "I'm willing to try anything. I just keep coming back to the feeling that I'm dependent on Ativan after my 2.5 weeks of taking it daily with Benadryl, following the bad reaction to Zoloft. I feel addicted to it, and I feel like I'm not being heard that is a possibility. I feel like we are throwing all these different meds at my insomnia when the root cause is Ativan dependence. I don't feel any of the anxious thoughts I had before. I feel completely numb." So you got that message from her at 9:04, correct?
I did.
And what was your concern when you got that message, or did you have any concern?
I wouldn't say I had concern. I just wanted to, again, provide her some information about what I thought might be happening.
Based on your training and experience as a psychiatric
I'm
nurse,
sorry, she didn't finish her answer, please.
Okay, yep. Go ahead.
I was finished.
Okay, well, she's finished. All right, next question.
based on your training and experience as a psychiatric nurse, And you said you had some experience with substance use. Did you feel that there was a dependency issue or an addiction issue with the Ativan?
I did not.
Is it fairly common that Ativan is going to make somebody feel better if they're feeling anxious?
Yes.
That's why you take it, right?
Yes.
And that's why you take it as needed. Is that fair to say?
Yes.
So in your response to her at 9:37, do you make clear to her the difference between dependence and addiction?
I do.
Okay. And as far as benzodiazepines go, there's a real concern for dependence and addiction in the fields. Is that fair to say?
Yes.
But based on taking it for 2.5 weeks, taking it to address actual symptoms of anxiety, did you have a concern of dependence?
No.
And so did you articulate to her that anything about that concept of dependence versus addiction? What did you say?
I said, I wonder if you fear you're becoming dependent on the benzodiazepines, and there's a subtle difference between dependence and addiction. With addiction, there's a change in behavior caused by biochemical changes in the brain after continued substance abuse. The substance use becomes the main priority of the person with the substance use disorder, regardless of the harm it causes to themselves or others. With dependence, we're referring to physical dependence on a substance characterized by symptoms of tolerance. Characterized by symptoms of tolerance and withdrawal. Benzodiazepine withdrawal is similar to alcohol withdrawal symptoms. We would be seeing things like elevated vital signs, high blood pressure, tachycardia, diaphoresis, mild alteration of mental status, initially with a possibility of perceptual disturbances, delirium, dysphoria, and tremors. Did the insomnia predate the Ativan use? I hear your concerns about the benzos. So my recommendation is do not take them every night. I recommend taking only every other night, and then we will not refill it.
And so what's diaphoresis?
Sweating.
Okay. And in the fields of prescribing psychiatric medications, do you often have to deal with physical dependency and then addressing it later?
I wouldn't say often.
Is there a way to address that as far?
Absolutely, yeah.
And so that wasn't a concern of yours regarding Ativan, was it?
Not at that time.
And what about her statement about not being heard? Did you see that in her message? Where she says, I feel like I'm not being heard about addiction.
That being a possibility.
As a psychiatric nurse practitioner dealing in psychiatric medicine, is it important to you when a patient tells you that I don't feel I'm heard?
Yes.
And do you take that in consideration when addressing them and continuing to build that relationship?
Yes.
And so in this case with the defendant, with Lindsay Clancy, did that change your approach with her at all?
It's why I sent the message that I did, trying to explain what addiction versus dependence and tolerance is. And I wanted to reassure her that we will try to have you take these less frequently and we don't need to continue them moving forward.
So she advocated for herself and you took that into consideration and created an alternative plan or suggested an alternative plan?
Yes.
Did your care of her change at all when she told you she wasn't being heard?
I wouldn't say it changed.
You treated her as you would any other patient, right?
Correct.
Now, you continued to have messages with her throughout that day. Is that fair to say?
Yes.
And so at 10:02, you receive a message from her. Says, the insomnia started from the Zoloft, but then after the 2 weeks of daily Ativan and Benadryl use, that's when the insomnia was at its worst. I've tried so many different sleeping aids at this point, Trazodone, Ambien, Remeron, Seroquel, and they all seem to barely touch the sleep until I take Ativan with them. So tonight I will try 15 of Remeron with 50 of Seroquel. I fear that if I wake up in the middle of the night with intrusive thoughts again, I will feel like I need Ativan. Do you recall her sending that message at 10:02?
I do.
and that she sent another message. It's kind of cut off, but it's still within the 10 o'clock hour, where she adds, I also just feel concerningly numb right now. Like I have no emotion whatsoever. I feel like I'm going to die and I don't care. What do I do about this?
I do recall that message, yes.
And this is a message that she sent when she would have been or have seen Letitia Dukes already, right? If she had a 9 o'clock appointment.
Yes.
When she sent that message to you, did you respond back to her at 11:35?
I did.
And with the fact that she talked about being numb and having no emotions, feel like I'm going to die and don't care, what did you do?
I said, this sounds like depression and anhedonia symptoms. I would say if you're feeling unsafe, particularly as we head into the weekend, it is important for you to have information for psych emergency services available to you. And I provided a list of the 24-hour emergency service programs like mobile crisis intervention.
Okay. And when you say anhedonia, excuse me if I mispronounced that, what does that mean?
Anhedonia is a symptom of depression where people are unable to feel pleasure. You might describe it as feeling numb. They're unable to look forward to things.
And in her message where she says, I feel like I'm going to die and I don't care, did you take that as a suicidal thought or suicidal ideation?
No.
And so did you tell her to go to the ER right away?
No.
Did you have concerns that she needed to get a higher level of care at that moment when she sent that message?
My concern about that statement was that I wanted her to have access to resources if it escalated or if it worsened. So I made sure she had it.
Okay. And fair to say you also at the end of that message indicate, are you able to get rest or reach out to your support system so that you can be helpful, so they can be helpful to you right now, and that this is hugely important?
I did say that, yes.
And 11:41 a.m., she responds, yes, I have support. My parents are here to help. And again, this is 12:02. Does this sound like side effects to Remeron or Seroquel? I have never felt anything like this before. And then 11:57, she sends another message. Do you think over time these symptoms will go away over time? 12:04, another message from her. Is there any chance you could give me a call to discuss when you have a minute? At 12:10 p.m., and just to confirm, your recommendation for tonight is 15 Remeron, 50 Seroquel, and avoid Ativan even if I'm not sleeping. So you got those messages in succession, right?
I did.
And were you able to eventually respond to her with a phone call?
I responded to the message at 12:12 p.m. I wrote it down for her.
And again, in your response to her, did you reiterate that these are pretty common signs of depression, and that what she was expressing to you wasn't uncommon in women with postpartum depression?
Correct. I said it sounds more like depression than side effects. It's not uncommon for me to hear, I've never felt anything like this before, or I just don't feel like myself. All of this sounds like postpartum depression.
And did you further try to give her some encouraging words?
Mm-hmm. I shared a passage from a book called This Isn't What I Expected.
And is that book kind of centered around postpartum depression?
Yes.
And did you also tell her this is going to get better?
I said, even though they feel terrible, remember that they're symptoms of an illness that is very real and very treatable. This is going to get better.
And after that message on 12:12, did you in fact send her another message?
I did.
And fair to say that next message was to kind of address the concern about her question, what to take.
Yes.
And you confirmed to take 15 milligrams Remeron, 10 milligrams Prozac, and 50 milligrams Seroquel.
Yes.
And that taking Ativan every other day might help.
I said, I would say taking Ativan every other day might help you to see you are not addicted, as one cannot be addicted to something they don't take every day, but we can also decide to let me be concerned about whether you have a problem with the Ativan and simply take it nightly for now. And if I have concerns about your use of it, I will make them apparent to you. My primary concern at this time is that you sleep. And if that means taking the Ativan for middle of the night wake ups, that is what it means. I'm confident we can safely and successfully get you off Ativan in the near future. And then I also go on to make recommendations about if she does have trouble in the middle of the night, certain sleep hygiene techniques that she could do, like getting out of bed and doing something non-stimulating, and then go back down to try to sleep again when you feel drowsy.
So an alternative to medication intervention.
Yeah.
And then at 1:40 p.m., she responds, "Thank you. I'll stick with that plan. I really hope it works and to feel like myself soon." Right?
Yes.
And then at 2:35, you respond, we will follow you closely. We have lots of alternatives. If this for some reason isn't the combination, we'll find one that gets you back to feeling like yourself.
I did say that, yes.
In all your treatment of women, the women that you've treated with postpartum depression, is this common that you have to kind of trial different plans in order to find the right one?
Yes.
All right, Ms. Bucket, it's 11 o'clock. Why don't we take the morning recess at this time? All right,
Thank you.
so we'll take the break.
Court, all rise. Good. Try and close your notebooks. It's on the chairs, please. This way.
All right. Counsel, anything we need to discuss before the break?
Well, thank you, Judge.
All right, so we'll be in recess for the morning recess at this time.
since radar is estimating up to almost 90-mile-per-hour winds near Sycamore. Granted, that's off the ground a little bit, but still very intense winds all across this line. Here are some of the peak wind speeds across our line right now. So Mendoza's near 80, and then back up near DeKalb, we're approaching 90 just off the ground level. Also, Tornado Pagey is, I believe, now driving through some of the higher winds. So now the conditions are beginning to deteriorate where they are. If you look bottom right of your screen, they are now right on the edge of this line. So they are starting to get into some of the stronger winds. And it's pitch black. You can't really see much. It's almost pitch black here, and it's 10 in the morning. Very hard to see anything. The winds estimated by radar are about 30 miles per hour here, so they haven't gotten into the peak wind yet. They're about to enter into the town of Somonac and then Sandwich. Somebody just said, under my bed, is it safe there? You might have some monsters under there. You might want to be careful. Be safe. You got a dual risk. While we have about 20,000 of you tuning in, make sure to put your location on the map. You can scan the QR code. You can also go to the website linked in the description. You can put a message on the Weatherfront app here. Feel free to put your location on the map. We'll see where everybody's tuning in from right now. Got a lot of you guys already tuning in right now from the Chicago area. Some of you in Genoa. Shannon says it looks like 10 p.m. versus 10 a.m. I would agree with that. It does right now. We also got somebody over here in Rochelle that said skies almost got black, crazy wind and rain. So Caleb has already gone through this back over there in Rochelle. And some of you are about to go through this over the next few minutes. Again, this line rapidly approaching the Chicago area. There's several little areas of rotation again near Ottawa that could easily spin up a tornado or two. I don't think any of these really are enough for a tornado warning. This one was a second ago. I think it's just a little bit broader now, but any of these could pretty much drop a tornado here near Ottawa and Dayton. They might not issue a warning for it though, just with how minimal the rotation has been over the last few minutes. I'm also monitoring at least a possibility for a tornado to form here near Aurora over the next 10 to 15 minutes, depending on how this part of the line evolves. But at the bare minimum, we are talking about a significant damaging wind threat that is about to be knocking on the doorstep of Aurora here in just a moment. Terminal radar site, which does tend to have a little bit better view of our rotation, doesn't show anything really different from what we were just looking at, but there's at least some broad rotation developing, only about maybe 7 miles west of Aurora, and it will be entering Aurora here within the next 10, 15 minutes or so. But currently, we're looking at these storms moving east at about 40 miles per hour, so they're moving pretty quickly through the Chicago suburbs. And it's only going to continue to produce a pretty significant, if not widespread, damaging wind threat here for the next, 45 minutes to an hour for the Chicago area. And then after that, it's going to go into Michigan and Indiana. The National Weather Service, or the Storm Prediction Center, just issued a new severe thunderstorm watch. This one will include Fort Wayne, Indianapolis, Lafayette, and Muncie. That is mainly for a significant damaging wind threat, but there will also be a possibility of a couple of tornadoes across this region. Also includes extreme southern Michigan and also northwestern Ohio near Lima. You guys are all under the gun here for a widespread wind threat. This will go all the way until 4 p.m. Central Time. So it's luckily mostly a daytime risk rather than a nighttime threat for many of you. Also, Cannon Colton has a really good view of the shelf cloud. You can barely see it, but you can see it a little bit coming out of the horizon here. He's located over near Elgin. And so you can faintly see the shelf cloud from here where he's located. That's going to be that leading edge of damaging wind gusts, which is quickly approaching St. Charles and Elgin at this moment. So we are going to go back to him in a second, but he's at least getting a view of that now. He's only I want to say 4 miles away from this line. He's not even that far. He's only 4 miles away from the line. In some cases, you can see the shelf clouds from 15, 20 miles away. Today, it's only visible from 5 miles away. That's the first glimpse that we've had of it, at least with him. All right, let's go back down to the Ottawa area. Again, this is the 10:03 p.m. radar scan, so this is about 3.5 minutes old, but we still have a few areas of circulation near Ottawa. Again, not a major tornado concern right now, but we could see a couple of spin-up tornadoes. We have somebody over here in Dayton that is saying it is bad in northern Ottawa, which is also where we have a little bit of rotation. Tom says there's hail. I don't know about that, but apparently he's saying there's a little bit of hail out here. The National Weather Service has all of our severe thunderstorm warnings for no more than dime-sized hail, which is basically around the size of 1/2 inch to 3/4 inch. I don't think there's going to be much hail out of this line. If you get hail, I'd be surprised. This isn't really a good hail setup by any means. This is very much so just going to be a big wind threat. We do have a couple storms over here in northwest Indiana that have been trying to broadly rotate. These are a little bit more discrete in nature, so we got to keep an eye out on these storms near Couts and North Judson. could have at least a low-end tornado concern developing here over the next half hour, 45 minutes. Storm chaser Connor Croft, who's bottom right of your screen, is actually on that activity, so we're going to keep an eye out on him. But it got a couple storms that look like they're trying to rotate over here in northwestern Indiana. We got big flash flooding problems that are also going to develop here as this area of thunderstorms continues to push down to the south and east. Let me go back to the Chicago area, and that right there near Plano and Aurora is looking a bit more concerning. And the reason why I say that is because, one, we got a big surge of wind, but two, we also have some inflow that's trying to creep in to this leading edge of the line near Aurora, and that might lead to a tornado threat here over the next few minutes heading to the Aurora area. Not saying it's enough for a tornado warning yet, but definitely stay on high alert if you are in Aurora, Bolingbrook, Plainfield, or Oswego right now. In addition to this, we're looking at a widespread 80-mile-per-hour wind threat, so do not take shelter. You should be taking shelter if you're in this area, regardless of there being a tornado warning or not being a tornado warning. We have several areas of rotation still back down near Marseilles and Grand Ridge. Any of these, again, could produce a tornado. We got like 3 or 4 different couplets that are trying to form right now. This is all going down I-80 heading towards Shanahan, so definitely stay on alert there. And Cannon Colton is currently on the line here near Virgil, Illinois. This is the leading edge of the shelf cloud here. Thank you, Shane, for becoming a member. So here's the leading edge of the line. He's just southwest there of Elgin. This portion of the line is currently estimated winds are about 70 miles per hour. Dude, I was about to head into Summonack. I didn't even hear about that. I didn't even know that town exists up until now.
So let's pull off right here.
I know most of the
Face of the wind in this one.
with how many times we've covered Illinois this year, I know almost every single town name at this point, but that is one that I've never heard of up until today. So there's the leading edge of the line. It's going to get pretty windy here in a second, but he is currently located just west of Elgin there. If we go back over to live radar, I'm really concerned about this little pocket right over near Plano and Sandwich. Tornado Pagey is not even far from that. That, again, could become tornadic. We got a big surge of wind happening near Aurora right now. Trying to see if we have any more terminal radar site views. There's a few little pockets of rotation that have been forming. Again, nothing that has gotten to the point enough for a tornado warning. I do think the rotation, though, down here near Ottawa, just south of Sandwich, could end up getting tornado warned. That rotation has looked a little bit stronger over the last scan or two. It's a pretty classic QLCS tornado threat. This will be going more towards Joliet and Shanahan. So we are going to keep tabs on that. Cannon is now starting to get into the wind here. So this is going to be the first surge of probably 2 or 3 surges of wind that are going to be impacting the Elgin area.
Intercept, so let's see.
I do want to point out, by the way, guys, if you live in the path of this line of thunderstorms, you could actually experience a derecho today.
Nobody on this road.
Not something that happens very often, only happens maybe a few times a year. All right, but we could legitimately get a derecho.
A new tornado warning has been issued.
All right, guys, we got a big tornado warning here. It's going to include a lot of areas. We got Cook, and this is, we were talking about this for a few minutes. Cook, DePage, Kane, Kendall, Will counties, you all got to take shelter right now. We got a tornado warning here for Aurora and Joliet. This is a rapidly organizing area of rotation that is moving towards the Chicago area. All right, so take shelter. Aurora, Sugar Grove, Yorkville, Plainfield, Lockport, Romeoville. You got to be taking shelter right now and put as many walls between you from the outside as possible and get away from windows. This is a pretty dangerous storm right now that's moving into Oswego. We got rotation rapidly organizing right now north of Yorkville. All right, so you got to run to your safe place, put as many walls between you from the outside and get away from windows. Aurora, North Aurora, Naperville, Downers Grove, Bolingbrook, as well as Romeoville and Lockport. Y'all got to run to your safe place right now. I also want to point out, on top of there being a tornado risk, we got 90-mile-per-hour winds that are being estimated by radar right now. So this is a very dangerous situation. I would also support an extremely dangerous situation, severe thunderstorm warning for this. Riley has an update. Go ahead, Riley.
Hey, Max, I want to talk about the Max alert that we just issued. And this is actually a really big one. This is something that we've talked about back and forth with QLCS tornadoes about being able to do, but
So if you're anywhere in this area,
we maybe talk about a quick setup tornado, but just maybe two radar. Go ahead. Issuing up 40 back. It's falling down.
Thank you, Riley, for the update. I don't know where his face is. I'm not going to lie. I don't know what happened. Zoom broke for some reason, but thank you for the update. So we got a big max alert right now. Again, that is for Chicago, Oak Lawn. Also for those in Elgin and Carpentersville, we are watching for at least a low-end tornado risk right now. So get ready for this. Take shelter, again, if you're really anywhere in the Chicago area, and put as many walls between you from the outside as possible. This is going to be a pretty dangerous line of thunderstorms that is producing widespread damaging wind gusts right now, in addition to an increasing tornado threat. That is, again, over near Aurora and Oswego, where the main area of rotation is currently located. This is Tornado Pagey. They are on the edge of the tornado warning right now. They're in Sandwich, and the conditions look pretty wild out here. These conditions are no joke. It's getting very windy out here. This is on the back side of the line. Riley, join that, or let me test it. All right, it should be working now.
Holy cow, someone reported a baseball.
Apparently there's baseball-sized hail in Indiana. Where was that? We got a destructive severe thunderstorm warning. Well, that'd be why. Over in Knox and North Judson, we got baseball-sized hail falling right now, back over west of Plymouth. That's a big-time thunderstorm. Riley has an update. Go ahead, Riley.
Hey, Max, it sounds like they didn't hear me as well as not seeing me, so we're going to repeat everything I just said. We issued a very large max alert for basically the entire Chicagoland area, and we're doing this because it's sort of a tornado advisory. We're tracking a lot of different QLCS couplets within this area, and there's a chance we may see these things spin up just in between radar scans. So anywhere in this polygon, we're not saying, hey, there's probably going to be a tornado yet here, but there is the potential for it. So we're going to start by basically highlighting that entire area as a tornado advisory, sort of in between that watch and the warning, and then we're going to be issuing max alerts inside this polygon once we see the more chances of a QLCS tornado itself, sort of with those specific couplets. So if you're anywhere in this area, just keep an eye out. There's definitely rotating storms on the way, and you may be upgraded to a tornado warning at any time.
It's nice to see your face. Thank you, Riley, for the update. Back over near Aurora, we do have, again, an increasing tornado threat. Look at this latest scan. We are getting a big surge here of RFD right over Oswego. The winds, guys, are going to be insane in Aurora. I mean, we're looking at some velocities that are being picked up near 95 to 100 miles per hour right now. Aurora, you've got to run to your safe place, guys. I don't care where you are in this tornado warning. You've got to run there. It doesn't even matter if you're in the tornado warning or not. This is a very powerful part of the line of thunderstorms that is now producing damaging wind gusts up to 100 miles per hour, in addition of a tornado risk right now. I also want to point out, guys, that we have a tornado warning here for 1.2 million people. So if you have friends or family that are in this tornado warning, alert them. Feel free to share the stream. We are providing commercial-free coverage here on YouTube and also on Facebook with a very powerful thunderstorm that is moving right into Aurora. Damaging winds up to 100 miles per hour are possible. That is not a radar bug. That is legit. That's literally happening as we speak in Sugar Grove, Illinois. That's about to hit the Prime Healthcare at the Mercy Medical Center in Aurora, and Oswego is going to be taking a direct hit from this over the next minute or two. The velocities are very intense here. We were talking about a potential tornado risk in addition to just a really intense wind threat moving through a very populated area. We also have a new max alert for those in Grundy and LaSalle counties. If you live in Morris, we are watching an increasing tornado threat right now. So get ready to take shelter if you are in Morris. Damaging winds will also be up to 75 miles per hour as this line of thunderstorms moves through. But really, the big story is going to be the storm right here near Oswego. I mean, we are looking at a big surge of RFD, which is that rear flank downdraft. That's the wind that is coming from the thunderstorm. And then anything else would just be inflow that is heading into the storm here. That'd be the red, which we don't have much inflow, but if we even get a little bit of inflow, this thing's going to be cranking and trying to produce a tornado risk. You can see the reds and greens, though, coming together right now, right over the west side of Oswego at the 1013 radar scan. We'll have a new radar update here in just a moment. But with all this convection that's clearing out in front of this storm, we're starting to see all that RFD push out, and that's why we have that increasing tornado risk right now just outside of Chicago. We also have storm chaser Ryan Scholl, who you can also watch live for free inside of the Weatherfront app. He is live right now over in Joliet. He is inside of the tornado warning, so we're going to be keeping an eye on him. Tornado Pagey is located in Sandwich. They're hitting a lot of red lights. We got a PBS red light alert over there, but they might be able to see something here pretty shortly. But we'll have a new radar scan here in a moment. They just continued this tornado warning. It's been condensed very, very minimally. This is, again, for Cook, DuPage, Will, Kane, and Kendall counties. All right, so if you live anywhere in this area, we are watching for a pretty elevated tornado risk embedded in this line. And if we do get a tornado, it could easily be strong. That is one of the reasons why we really got to be taking this seriously here. If you live in Naperville, Bolingbrook, Romeoville, or Plainfield, or any surrounding location. The National Weather Service just issued a new severe warning with a tornado possible tag. This will be a destructive severe thunderstorm warning. All right, so this is another kind of warning that you should be taking shelter for. We are talking about 80-mile-per-hour damaging wind gusts for Joliet, Beecher, and the south side of Chicago. This severe destructive warning here includes 3.3 million people. All right, so 3.3 million people are in this new destructive severe thunderstorm warning. This does not really include the downtown area of Chicago, but includes a lot of southern Chicago here. Downers Grove, Bolingbrook, Oak Lawn, Orland Park. We all got to be taking shelter. This is a very dangerous line of thunderstorms, and it might even be producing a tornado right now. The area of rotation is currently located right over the town of Oswego. So if we have a tornado, which we are very close to potentially having one here in Oswego, it's going to be moving into Plainfield. All right, so Plainfield and Romeoville, you guys are going to be in the path of this. I also want to point out there is a CC drop here, but I believe that is in the clear air part of the thunderstorm. So I do not think this is a tornado. I do not think that's a debris signature, but if we had a tornado, it would be basically going through the downtown area of Oswego, Illinois. In about 4 minutes, it'll be hitting Plainfield. So Plainfield, you guys are going to be hitting about 5 minutes or so, 4 or 5 minutes. And then after that, Lockport, Romeoville, and Bolingbrook. You guys got about 10 to 15 minutes until that area of rotation hits you guys. Also, there are several areas of rotation down here south of the tornado warning. We got a couple near Braidwood that are forming. And then there's one over near Morrisville. They have not issued a tornado warning for that, but we have a max alert for that for at least a possible tornado risk. And then most of everything else is a damaging wind risk. There's a little bit of rotation also near Nettle Creek. That's going to be heading into Saratoga and Channahon. So if you live in Channahon or Saratoga, we got to be watching for that little area of rotation there. This latest velocity scan has this is 1 pixel, but it has winds up to 101 miles per hour. That is going into Oswego right now. Let me see. We got a lot of people tuning in here. Let's see. We got some people that are right next to this area of rotation. It's Oswego? Is it Oswego? Person said, hey, Pookie. I'm not your Pookie. This is Ashley saying super dark and eerily calm here in Yorkville. Well, it's probably windy there now. We can hear the tornado is what somebody said over here on the north side of Yorkville. I don't know if we had a tornado, but Ethan says they can hear the tornado. Oswego, my bad, guys. I've been saying it wrong for the last 10 minutes. Payton says winds are starting to hit. Trees are really shaking bad. Sirens, no high winds yet. That was a few minutes ago. And we also got somebody else saying, chill with the dog on the couch. Can't see the shelf cloud from here. The shelf cloud is going to be hard to see. The shelf cloud is actually very hard to see right now. The visibility is not great out here. Like, it's going to be pretty difficult to see anything out there. I wouldn't really be trying to look outside, but the winds are going to be very intense. And obviously, we got a tornado threat rapidly coming in right now. I'm going to go ahead and put the locations on here. So they're only like the last 5 minutes. I know a lot of you are submitting your location here on the Weatherfront app. We're going to probably leave that to the last 5 minutes. So these are a little bit more recent. Illinois never gets a break. Yeah, Illinois is literally never going to get a break, guys. I hate to break it to you. We're going to get another tornado probably in September, which hardly never happens. We have a new severe thunderstorm warning for Chicago and Kankakee. This should include like 6 million people, I think. I don't know the exact number, but it's probably a lot. We have 3.3 million people under the destructive severe warning. We have 1.2 million people under the tornado warning. And this new severe thunderstorm warning includes 7.1 million people. So that includes Chicago, Kankakee, as well as Braidwood and Beecher, Channahon, and east of Elgin. All right, we got 70-mile-per-hour damaging wind gusts that are quickly coming towards you guys. So you got to be taking shelter if you're anywhere in this destructive severe thunderstorm, in this considerable severe thunderstorm warning. There's also a tornado possible tag on all of that activity right now. All right, here's the latest scan. Looking at a possible tornado right now northwest of Plainfield. You can see the hook echo very clearly on this latest radar scan. That's located on 22, just southeast of Oswego, moving into the town of Plainfield, Illinois right now. Tay says it's spooky, and that is just a big surge of wind. I'm not seeing much rotation. I'm seeing a really powerful surge of wind, though, right now, going right towards Keller's farm stand. And also hitting the Henberry Forest Preserve. We got winds being estimated near 95 miles per hour right now. I also think we might need a tornado warning near Saratoga. There's a couplet rapidly forming there near Saratoga and Shanahan. This is moving from west to east. Joliet could also be in line for this area of rotation, Manhattan, and then eventually going towards Elwood. You guys are also in the path of a possible tornado risk. I would support a max alert for that. That is a organizing area of rotation embedded in our line of thunderstorms. This is the... And there you go. Now we have an extremely dangerous situation, severe thunderstorm warning. All right, so this is now the highest level severe warning that you can get. That is going to include areas in the Chicago area. All right, so they have upgraded this destructive severe warning. It is now for still 80-mile-per-hour winds, I believe. Yeah, so this is still for 80-mile-per-hour winds, but local observations at 10:15 a.m. are reporting 85-mile-per-hour wind gusts in Sugar Grove, Illinois. So the Chicago metropolitan area, mainly the southern portion, you guys are under this extremely dangerous situation, severe thunderstorm warning. You need to take shelter now if you're anywhere in this area and put as many walls between you from the outside as possible and get away from windows. I'm not saying this to try to scare you, but this is a very dangerous line of thunderstorms that is producing a very widespread wind threat right now. In addition to the potential for tornadoes, which the highest tornado threat that I can see right now is just east of Oswego. And then there's another one over the town of Aurora that is developing right now, which is embedded in our tornado warning. But we also have areas of rotation like the one near Saratoga that are currently not tornado warned. And that one could also drop a tornado. So it's very important if you live in these areas to please be taking shelter. If you live in a mobile home, try to get to a sturdy structure if you can, as this is going to be a very dangerous line of thunderstorms here over the next 30 to 45 minutes as it pushes into the Chicago area. The worst of this, again, is really in the tornado warning. That's where we have very intense winds happening. No debris signature for the time being, but we could really have a tornado here at any moment. And over the last couple of radar scans from the terminal radar site, it is showing the main area of rotation approaching the town of Plainfield in Romeoville. There's a little bit more near Aurora that we're keeping an eye on for. Let me go to this other terminal radar site. And so, yeah, if we have a tornado over here near Plainfield, it is going to be coming into the Edward Outpatient Center, which is on the north side of Plainfield. Also got the Aldi on the north side that'll be in the path. This Moe's Joe's, Larry's Diner near Lockport Drive, and then eventually going over towards Romeoville. Lockport is only about 7 minutes away from this. And then Naperville, you guys are only maybe 4 or 5 minutes away from getting really hit by this line here. We got a new radar scan coming in here in just a second, but again, very dangerous line here moving into the Chicago area. I am going to go ahead and put Storm Chaser Ryan Scholl on the bottom right side of your screen. He is currently live in Joliet. Who all is tuning in from the Joliet area right now? Ryan Scholl's out there in the downtown area of Joliet. He's about to get absolutely whipped by wind here in a second while he's probably driving. Storm Chaser Ken Colton, he's back over near DeKalb right now. And then you also got Tornado Pagey. They're struggling to keep up with this line, but they're over in Yorkville right now, which is where there's still some strong winds, but not nearly as intense as the leading edge of the line. All right, we got a new radar scan that just came in. And I mean, man, look at the wind here. It's actually unbelievable. It is so intense right now near Plainfield. This is going to be a really dangerous storm here for Plainfield. We're looking at 98-mile-per-hour winds that are being estimated by radar going right into the town of Plainfield right now. Let's go ahead and see if we have any sort of CC drop. No tornado actively from what we can see on radar, but the velocities are definitely strong. We're very close to having a tornado near Plainfield. This will be coming up on the Lewis University Airport in about 5 minutes, and then Romeoville's in the path of this, just southwest there, Bolingbrook. Also, we have a new max alert. This was issued by meteorologist Xavier Burns for Grundy, Kendall, and Will counties. That is Saratoga and Shanahan, with a rapidly organizing area of rotation that is quickly getting rain wrapped over in Saratoga. So if you live in Manuka or Shanahan, we got to be getting ready here for an increasing tornado threat. There's another area of rotation also just off to the south of that in Morris that could also try to produce a tornado risk over the next few minutes. But otherwise, it's a big wind threat. Going back to the Romeoville area, if we go back to velocities here, some of the other areas that are seeing some really strong winds are on the south side of Aurora. We are starting to see some winds as high as 90 miles per hour being estimated by radar just south of Aurora, just northwest there at Plainfield. Really, I think Plainfield right now is taking a major hit from wind. I know we don't have any sort of live views in the Plainfield area right now, but we do have Ryan Scholl, who's in the tornado warning. But I can only imagine how windy it is out there right now. I mean, it has to be pretty bad. The winds are very intense according to radar. And if we go over to the terminal radar site, the rotation is definitely strong. Not enough evidence to say there is a tornado from any of the radar sites that we're looking at, but we're very close to having one. But regardless of that, the damaging wind threat will definitely be one of the bigger concerns here as this line of thunderstorms pushes into the Chicago metropolitan area. Thank you, Kat, for becoming a member. Thank you also, Jeremy, for the super chat saying near Route 59 in Naperville Road, we were told to be in the basement for a while at work. I'm not surprised. This is a very powerful line of thunderstorms. In case you are just tuning in, we do have a destructive severe thunderstorm warning for those just south of Chicago. This is an extremely dangerous situation. This is the highest level severe warning that you can get issued. What that basically means is that we need to be taking shelter. There's no reason to not be taking shelter right now. If you live in the south side of the metropolitan area here of Chicago, there's over 3 million people that are under this warning. If you have friends or family that need weather coverage right now, feel free to share our stream. We are live again on YouTube and Facebook with commercial-free coverage. We got a very intense line moving into the Bolingbrook and Romeoville areas right now. There's some rotation over Plainfield that could be dropping a tornado at any moment. And then after that, Orland Park, Oak Lawn, Chicago Heights, and Chicago, you are going to be in the crosshairs of a very dangerous wind threat. Once again, we do have an official reading coming in
tornado warning
of an 85-mile-per-hour wind gust, actually 2 over in Sugar Grove Airport. So we are starting to see more reports now of really intense winds being reported over in the Sugar Grove Airport area, which is just outside of Aurora. We have a brand new giant tornado warning here. This is going to include Shanahan, Braidwood, Manteno, and Beecher. So if you live in Will, Kankakee, Grundy, or Kendall counties, we have to be taking shelter and putting as many walls between you from the outside and getting away from windows. This is also going along with a significant damaging wind threat that is currently happening right now. If we go back over to velocities, they'll update here in a second, but our main areas of rotation are over near Morris, Oxable, and Manuka. That is where the main circulations are currently located. Here's that latest scan. So we have one east of Morris. We have another one basically paralleling U.S. Highway 6 just south of Interstate 80. And further south, there's a broad area of rotation that is going into the Braidwood area. So take shelter if you're in that part of the warning. And then over near Plainfield, the main area of rotation is over downtown Plainfield. All right, so if we have a tornado, it's going to be on the west side of Plainfield. We just cannot definitively say there is one at this time, but if there is one, it's going right through the town of Plainfield. And then after that, it's going to go into Lockport, Homer Glen, Marley, New Lenox. You guys are in the path of this. Also, over in Naperville, we are starting to see at least a broad area of rotation form. That is over near Warrenville. That is not currently tornado warned. I think they may have just warned it. That is Cook and DuPage counties. That is for Chicago. All right, so they have issued a tornado warning for this. That is Addison, Wheaton, Downers Grove, and Chicago. You all need to take shelter. All right, we got the area of rotation quickly developing right now, right over the town of Wheaton and Warrenville. That's going to approach Lisley. And then it's going to go into Hinsdale, Brookfield, Westchester, and also Melrose Park. I'm pretty sure there's like 4 million people in this tornado warning. We're going to get the exact number here in a second. But rotation is rapidly organizing right now, right over Warrenville. That is near Butterfield Road. And that's about to hit the Illinois Institute of Technology at Rice campus here in a second. So we got rotation quickly forming on that little part of the line here. And so, again, that's right over Wheaton. It's approaching Interstate 355 right now in Downers Grove. You got to be taking shelter and get there quickly. This is a fast-moving line of thunderstorms. The National Weather Service here is trying to issue tornado warnings as far in advance as possible because this line is just moving so fast. I mean, it's moving east at 55 miles per hour. In about 25 minutes, you're not going to think much of this unless you get hit by something. You're not going to think much of it because it's going to be out of here probably in about half an hour or so. So the next 30 to 45 minutes for Chicago going to be crucial to be taking shelter here. All right, let's go back over to the terminal radar site. Rotation is looks like pretty strong right now over Warrenville. There's a lot of range folding, but we got a lot of wind right now impacting the Warrenville area. Potential tornado, again, over Warrenville, Illinois. If we do have a tornado, it will be hitting the Morton Arbor. I don't know how you say that. I'm terrible at pronouncing stuff. This is also near the Illinois Institute of Technology Rice campus. Glen Ellen Village Links Golf Course. You guys are in the path of this over the next minute or two. And also the College of DuPage. We got to be taking shelter there. That's on the southeast side of Wheaton. I'm not sure if any colleges are really back in session here in the Chicago area, but if you are, or if you're just there in general, that tornado threat would be approaching you guys over the next minute or two. Apparently, this is Lisle right here. So Lyle's about to be hit by this. And then after that, Downers Grove and then Brookfield, you guys are going to be in the path of that rotation. We still have a lot of rotation on the east side of Plainfield. That's near Interstate 55 going into Lockport. The terminal or the regional radar site is about to be directly hit by the surge of 80 to 100 mile per hour winds and also the possible tornado.
Might be cooked.
So we got to watch out for that. Ryan Scholl is over here in Joliet. He says he might be cooked. He's right now in downtown Joliet. So we're going to be keeping an eye on him. He's about to get cooked by this line of thunderstorms. All right, we got a new radar scan coming in. We're going to see what it looks like here. And in case you're just tuning in, we have about 7 million people, I think, under tornado warnings right now, or 6 or 5. We have 3.4 million people in this tornado warning. We had about 1.2 in this one, so that's about 4.6, and I think this one's about 100,000. So we basically have almost 5 million people right now under tornado warnings, all in the Chicago area. And then we have this extremely dangerous situation, severe thunderstorm warning, which is for 80-mile-per-hour winds, which includes, I believe, 5 million people or something crazy. It's a very large number. All right, here's the latest radar scan. Going from south to north, back over in Wilmington, there is still a couple areas of strong rotation. We've had no definitive evidence of a tornado with any of this part of the line so far, but there have been many couplets that have formed that have been
Court, all rise. Jurors entering. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the matter Commonwealth versus Lindsay Clancy. All parties are present, including the 18 jurors.
All right. Read Buckingham, please.
Thank you. Nurse Gelato, when we broke, we were talking about your interactions via my chart with Lindsay Clancy on December 2nd of 2022, right?
Yes.
And so the last one on December 2nd at 2:35 p.m. was from you to her. And then on December 3rd, do you recall that a My Chart message was sent on that day at 7:24 p.m.?
I do.
And you were able to review that message some point after it was sent?
I was.
And she reports to you basically that she didn't want to wait to let you know some things that were fresh in her mind. And it says, last night I didn't take Ativan. My dose had been the night before at 1 a.m., only slept about 4 hours at the beginning of the night, about 9:30 to 1:45. Then I dozed off for maybe another 45 minutes from 4:30 to 5. Today, all day, I had horrible, intrusive thoughts and felt deeply depressed. I finally took a 0.5 of Ativan at 6 p.m. and now the thoughts are gone and I feel good. You recall receiving that message?
I do.
Okay. And fair to say there was no more communication between you and her until December 6th.
Correct. I believe December 3rd was a Saturday.
And you actually were out of the office on the 5th with sickness.
I was.
But you were aware that Lindsay Clancy did reach out to the office on December 5th.
Yes.
And that the nurse was able to respond to her to let her know that you were out sick, right?
Yes.
And Lindsay Clancy responds at 8:30 a.m. that day that she would just reschedule. Lindsay reaches out to the nurse and says that's fine, she'll reschedule, and that she in fact changed her appointment with Letitia Dukes to a virtual appointment for that day, for December 5th.
Yes.
So on the 6th, when you return, did you have a scheduled meeting with Lindsay Clancy?
Yes.
And on this particular meeting on December 6th of 2022, do you recall if that was an in-person or a virtual visit?
It was an office visit.
Okay.
In person.
And so just kind of looking at the note from that day, from December 6th, it says encounter date December 6th. It says filed on December 7th. In the under chief complaint history, do you have it in front of you?
Yes.
the second paragraph says patient has verbally consented to this video visit. Is that just something that sometimes pre-fills into the narrative?
Yes,
But your memory was that this was an in-person visit.
it was.
Was Lindsay Clancy there by herself or with somebody else?
She brought in her husband, Patrick.
Had you met him before?
I had not.
Had you talked to him before?
I had not.
As part of your treatment plan or your course of treatment with Lindsay Clancy, was it your practice to speak with collateral individuals?
Yes,
And in this instance, did you feel a need to speak to collateral individuals up to this point?
not up to this point.
If you did, would you have requested that of her?
Yes,
And do you need her express permission to do that?
I do.
So on this particular day, she presented with her husband, Patrick, correct?
Correct.
And was there anything different about your approach to the meeting than your previous meetings with her?
No,
You still go through history, you go through how she's doing now, you do your mental status exam, you do your screenings, right?
yes.
And so first, just let's talk quickly about the screenings. The Edinburgh screen, what was her score on this day when she came in? Do you remember?
21.
And the GAD-7, fair to say that screen was a 19.
Yes,
So would you say that it was pretty consistent with the last time that you saw her?
Objection.
What's your objection?
My objection is that that's not right. He's now got a 21 Edinburgh scale. Prior testimony was not anywhere near 21. It's deteriorated.
Well, I'm gonna allow that question. On cross-examination, you can certainly explore the basis of what her opinion was. So I'm gonna allow that question. Go ahead, Como.
Well, let me ask you about that score of 21. It's 21 out of how much?
30.
So in what range is that?
Moderate severe.
Okay. And on your previous encounter with her on, or your actual telehealth on November 29th, you reported that the score was 17 and that's moderate.
Moderate.
Right?
Yep.
And then on the GAD-7, on this particular day on December 6th, it was 19, right?
Yes.
And on the previous visit, it was 14.
Yes.
Okay. So as far as your observations of her on December 6th, did you notice anything different about her speech and language?
No.
How about her mood? What did you note her mood to be?
Anxious.
And the affect, fair to say, consistent with mood, meaning anxious, right?
Yes.
And thought process.
Thought process was linear and goal directed.
And thought content, did she indicate to you whether she was experiencing any auditory or visual hallucinations?
No.
Any delusions?
No.
Any suicidal ideation, a plan, or intent?
No.
And as far as your observations of her during this interaction, this in-person visit, did you observe any signs of psychosis?
No.
Did you observe any signs of mania?
No.
Did you observe any signs of obsessive thoughts or compulsive behaviors?
No.
Now, when you met with Lindsay and Patrick on December 6th, did she or did they report why Patrick was there?
I don't recall if they indicated why he was there. I understood it to mean he was there to provide collateral and support for her.
Were you aware that he was coming to the appointment?
I don't recall if I was aware beforehand or not.
And you had engaged in a pretty significant my chart back and forth with her in the days preceding this this meeting on December 6th, right?
Yes.
Did she ever indicate to you Did she ever indicate to you in those messages that she wished to bring him along to one of the visits?
No.
fair to say when a person brings a collateral and is willing to have somebody speak, you're more than happy to get that information?
Absolutely.
This person, this collateral person, can they offer you a different perspective about the patient and what they're going through or what they're, how they're presenting?
Yes.
In this December 6th meeting or the visit, did she report to you some changes in her sleep or significant concern for sleep?
I would have to review the note. What I remember is that the sleep really hadn't improved much beyond getting a few hours, waking up in the middle of the night, maybe piecing together.
Okay.
More time.
And fair to say there was some conversation to go back and talk about when symptoms started and try to get to kind of the root cause or what they believe the root cause of her symptoms were.
Yes.
And did Lindsay and Patrick report to you the connection with the Zoloft medication in September as a concern?
Yes.
And that at that they reported that, or she reported that exact night I went from 25 to 50 milligrams. I didn't sleep for 48 hours and I wasn't tired.
Correct.
So that's in your note as a quote, meaning that's directly what she told you?
Yes.
Did you express to the Clancy on this particular meeting did you express to Ms. Clancy thoughts that you had about her diagnosis based on your interactions over the last few weeks?
I did.
And what was that?
I discussed with her and her husband the possibility of potentially an underlying bipolar disorder. I based this on several factors, one of them being that she had such what we call an activating response to the Zoloft. It's unusual for somebody to describe taking Zoloft and then going 48 hours without sleep and not being tired. So that raised my clinical suspicion a bit. And she had been, I would say, having difficulty tolerating other antidepressant medications that we had been trying to have her take since then. And so again, I'm wondering if it's because potentially there might be an underlying, what we call mood disorder, bipolar disorder.
And as far as the information that you had about her past psychiatric history, were there any indicators to you about manic episodes?
No. So I do recall in reviewing Julie's note prior to meeting with Lindsay, she filled out what we call a mood disorder questionnaire. It's like a screener somebody can do to assess history of mania and bipolar disorder. Lindsay it was a negative screen. So there's 3 questions. One question has 13 different symptoms. You have to score 7 out of 13 on question 1, but also in question 2, it asks about, are the symptoms happening at the same period of time? And then it asks about any functional impairment from the symptoms. So I recall the 3 symptoms she did endorse were not sleeping for that period of time with the Zoloft and not feeling tired, having racing thoughts, and trouble concentrating. None of the other symptoms did she endorse. They did occur at the same period of time. And I don't want to be inaccurate, so I can't remember what she said for functional impairment, but I believe it was minor impairment.
Okay, and so the fact that those were reported, but ultimately the full screen revealed negative for potential mania.
I did also consider, though, that the MDQ is less specific when it comes to bipolar 2 or bipolar not otherwise specified. There's bipolar 1 and bipolar 2. Both have mania symptoms as part of the diagnosis. Bipolar 1 is usually more severe in that it's typically, a patient might be hospitalized or it causes greater functional impairment. Bipolar 2, it's a shorter duration and typically less functional impairment.
And as far as determining diagnostically whether somebody might be presenting with bipolar disorder, is there a particular tool you use in your trade to try to assess that?
Typically something like the MDQ, and then you'll do more of an interview asking the patient about symptoms specifically and if they can ever recall a time where this may have happened in the past, because sometimes patients can't always remember when they're manic. So I was glad to actually have Patrick in the visit because he could sort of help us look at Lindsay's history more longitudinally, or at least since the time he knew her.
Okay. And as far as, so those tools that you're talking about, the MDQ and kind of screening tools that you use in practice, is there another tool that you use to assess whether a person meets particular criteria to be diagnosed with bipolar 1 or bipolar 2?
There are others, not ones that I've used.
So are you familiar with the DSM-5?
Oh, yes.
Okay, so while that's not the end-all be-all, it is a guide that tells you specific criteria, how to determine if episodes are manic or depressive, right, when it comes to bipolar.
Yes.
The difference between mania and hypomania.
Yes.
And so while you noted that there were some concerns reported, did what was reported to you rise to the level of diagnostic criteria for bipolar disorder?
Not at that time.
Okay. And when you explained this to them, your thoughts about her reactions to the medication and these reported prior symptoms, did Patrick and Lindsay seem receptive to your diagnosis?
I recall Patrick saying my wife is not bipolar. Lindsay looked at me. She did not say anything.
Okay. And was this the first time in this meeting on December 6th where you broached that issue or mentioned that?
Yes.
Did the conversation continue about symptoms and managing symptoms after that?
Yes.
Were you able to get any more specific information from Patrick during that meeting? Not what he said particularly, but did you get additional specific information that kind of helped you assess whether you would change your diagnosis at that point?
No.
And were there still concerns in that particular meeting that the focus was trouble sleeping and the potential for addiction?
Yes.
As far as recommendations, did you talk about what's called tapering medication?
Yes.
And what were your recommendations regarding tapering?
So we talked about her concerns about the benzos. And we decided to come up with a plan to taper off of them.
And the last that had been reported to you via the MyChart messages was that she tried not taking it at all, ended up having horrible thoughts and felt deeply depressed, then took it and felt better. Right? So was it realistic to recommend completely stopping?
No.
So what is a taper? Like, why do you recommend tapers?
I recommend tapers to slowly get somebody off of something. And tapers can be useful because we might have somebody at a dose and they might say, oh, I'm too anxious to stop this, or I'm not ready to step down to another level, and we can kind of keep them on it longer. But at this point, since I had met her on November 29th and throughout the MyChart messages, there was multiple concerns voiced about benzodiazepines. And again, in this visit, so I even did what's called a CWA assessment, which is something we use to determine if somebody's having actual withdrawal from benzodiazepines or alcohol. Again, I really wanted to show her I was assessing this and taking this seriously.
When you say CWA assessment, is that an acronym for something?
Yes. So it's
what are the letters, just for the record?
CIWA. CIWA.
Okay. And did you, when you do that assessment, does it give you some sort of score?
It does.
Ask the questions. And what was her score when you did that CIWA assessment?
1.
And what does that mean?
Minimal to no withdrawal. The only symptom she reported was anxiety. Her blood pressure was normal. Her pulse was normal. She had no nausea, no vomiting, no tremor, no tactile disturbances. People in withdrawal from benzos or alcohol will sometimes feel like there's bugs crawling or pins and needles. Auditory disturbances, so hearing things, seeing things. No sweats, no headache. She was oriented.
Okay. So with that, and knowing that she wasn't in withdrawals for Ativan, did you still recommend the taper and an alternative?
I did.
What was that?
I recommended Valium. The reason I recommended this is she had discussed rebound anxiety with me at our very first visit, feeling that rebound anxiety above her baseline once the benzo wears off. Valium has an extremely long half-life. It can, as in like 100 hours. It has a longer clinical duration of action. So I wanted to offset the chance that she would experience rebound anxiety. And it's often used when we're tapering somebody on shorter acting benzos. It's common practice to switch to longer acting benzos to do this.
And did you also have conversations about the other medications that had been at issue, the mirtazapine and the Seroquel?
Yes.
What did the defendant, what did Lindsay Clancy express to you as far as Seroquel? Did she want to continue with that?
No.
Did she explain why?
So she felt like when she took Remron and Seroquel together, she felt weighed down and exhausted, but her mind was still awake and alert. And she just didn't seem to think there was a benefit to being on it.
And so did she express to you a desire to want to go back to trialing Prozac?
Both Lindsay and her husband expressed that that was their preference.
And was that something that you agreed with?
I did. I had shared with them that I had concern this could be bipolar. It's in my differential diagnosis, which is just all the typical diagnoses we might be considering. And that typically SSRIs are contraindicated, but she did have that history of being able to tolerate Prozac at 20 milligrams and do okay with no mania. So I thought that's what they were wanting to do, so we could do it. We could try it.
When you say contraindication,
okay, sorry.
What does that mean?
It means typically not something you would want to do if you were sure somebody had bipolar disorder, because if you put somebody on just an SSRI or like Prozac, like Zoloft, it can create a scenario where people are flipping back and forth, between manic symptoms and depressed symptoms, or they're called rapid cycling. It's not that antidepressants or SSRIs are never prescribed in bipolar disorder, but you often would want to have a mood stabilizer on board at the same time.
And so, despite your suspicions, you listened to the patient and went along with her request.
Yes.
So at the conclusion of that meeting, did you indicate that she could discontinue the Seroquel at that point?
Yes.
With the plan that she was going to restart Prozac?
Yes. Which I had been recommending the Prozac. Earlier, I believe even on November 30th, I had recommended it.
And with that previous recommendation, it was in addition to the Seroquel.
And the Remeron, yes.
So after this meeting on December 6th, did you have additional communications with Lindsay Clancy via the MyChart messaging on December 7th?
Yes.
And fair to say that those communications started as early as 9:48 a.m. when she sent the first message, right?
Let me just make sure. Oh, yes. Yes.
So on December 7th at 9:48 a.m., she sends a message saying, "Hi, Rebecca, last night did not go well at all. I took the Valium and melatonin and only slept from 9 to 1. Then around 2, I got desperate and took 25 milligrams of Benadryl and only slept about 1 more hour. What can I do? I really need help." So that was the message that you came into on December 7th, right?
Yes.
And did you respond to her in the messaging app?
I did.
And what was the response?
I'm trying to find the sequence.
Yeah, 10:19 a.m.
Okay. So I discussed, I mentioned, so your husband made a good point yesterday. Despite taking the Ativan in the evening, you were still only able to get a 5-hour stretch of sleep, which, yes, is improvement, but does sort of dispel the notion that benzodiazepines are the only thing that are helping you sleep right now, as you are still getting less than the target of 6 to 8 hours with Ativan, and the Valium did not help for sleep much at all. My next step in this case is to try a higher dose of Seroquel on its own. Are you feeling any subsequent loss of energy, exhaustion, fatigue with lack of sleep?
Why would it be the next step to increase from 75 of Seroquel to 100?
So she had been taking 50. So I was suggesting 75 to 100 would be my next step. Because again, bipolar is still on my differentials, and now I have the data that she only slept 2 hours. So I asked her the follow-up question, are you feeling tired? Or, are you feeling exhausted? Any subsequent loss of energy? It's still in the back of my mind that this could be bipolar.
So as far as the Seroquel goes at that point, creeping up the dosage, do you get now from the using it to treat insomnia to using it to treat something else like bipolar?
Correct.
And so that piece of it about feeling subsequent loss of energy and exhaustion, fatigue, why ask that?
Patients can have insomnia because they're anxious or because they're depressed, but typically they're exhausted or they're tired the next day, and it really does affect them. If a patient has an underlying bipolar, they could go on 2 hours of sleep and not feel tired at all, and that's unusual.
And so that is one of the signs, potentially, of a manic episode?
Potentially, yes.
So on December 7th at 10:33, she responds, "No, the weird thing is I don't feel tired at all. And she says, so just Seroquel tonight, question mark. I feel like I'm going to panic without a benzo with it. And then again at 11:44, another message, would I be able to do the Valium with Seroquel? Is that a safe option? So again, in this exchange with her in my chart, she's asking you questions to clarify what you've said and also alternatives to address the issue, right?
Right.
And as far as her questions go, and then her response about not feeling tired, how did you respond in the message?
So she kind of sent those in succession. So I don't feel tired, would I be able to do the Valium with the Seroquel? So I respond by, if you're not sleeping well with the Valium alone, there's no need to continue it, and I will prescribe a short taper to get you off benzos altogether. Because you are not tired at all and had a significant reaction to Zoloft at 50 milligrams, I'm concerned this is an underlying mood and bipolar disorder. I know you and your husband did not necessarily agree with that, but I feel that I'm going to send along this information to review. So I sent her a list of symptoms of bipolar, risk factors, so that she could have it to refer to.
And again, at this point, the only symptom she was reporting of mania was this not being able to sleep and not feeling tired, right?
And yes, and the racing thoughts and the trouble concentrating.
Okay, is that things that she had reported to you in your visit on the 6th?
No.
Okay. In these messages that she was sending to you in her on December 7th, she didn't talk about racing thoughts, did she?
No.
Okay, she just talked about the sleep?
Mm-hmm.
Okay. But based on a review of her history, she had at one point indicated that she was feeling those in relation to a symptom she was describing. Is that
correct?
So at this point, what do you recommend her to do?
I explained the importance of knowing if this is bipolar is significant, because SSRIs like Zoloft and even Prozac would be contraindicated. My recommendation is to do 100 milligrams of Seroquel tonight, 200 milligrams of Seroquel tomorrow night, 300 milligrams on 12/9, 400 on 12/10, and we will hold there. I actually say hold the Prozac, as I'm concerned this is a hypomanic mixed manic state.
And what about the Remeron at that point? Where did this fall into the mix, if it fell in at all?
I had recommended a very short taper on December 6th. I think I advised her to take half of a 7.5 milligram tablet for 3 nights, but in her message to me on December 7th, she had not taken it that night. So I had assumed she had just stopped that entirely.
Okay. Now, after you sent that message at 12:32, did she respond at 2:53, indicating that she would stick with that plan and that she said she needed a refill on the Seroquel because she only had 30 25 milligram tablets?
She did say that. There were actually a few earlier messages as well that day. I provided an alternative. One as an option, it quickly came into my mind, we're thinking about Prozac. We could add Zyprexa on board because there's actually a combination pill of Prozac, Zyprexa. The brand name is Symbyax, and it's for bipolar. And I said, for our purposes, we can prescribe them separately and take them both for the same effect. And I asked her to let me know which one she would prefer. And she responded, I think I would like to do the Seroquel with the Valium taper.
Okay, so that suggested alternative actually was on at 12:37.
Correct.
And then at 1 o'clock, she elects that she'd like to do the Seroquel with the Valium and asks for you to call in the Valium and the Seroquel.
Yes.
Okay. So that's on December 7th, right?
Yes.
On December 8th, at 6:35 a.m., she sends you a message saying, did well last night, need Valium, feeling panicky, don't know if ready to taper as quickly as planned.
Yes.
Kind of paraphrasing, but.
Yeah, she exclaimed, I actually did really well last night with the Valium and Seroquel. I mostly slept from 9 to 5 with a few wake ups, but was able to go back to sleep. She was concerned that she felt like she needed to take the Valium around 5 p.m. because she was feeling panicky. I feel really dependent on it. Can I taper any slower?
And what was your response to her request for a slower taper?
I said, I'm hesitant to taper any slower. Remember, Valium has a really long half-life, 100 hours, so you will have some on board in your system throughout the weekend.
And why were you hesitant to taper any slower?
I felt like she was anxious about being dependent on it, and so I was trying to facilitate the process of tapering her off, and I was clinically thinking we could cover her symptoms of anxiety as we titrated the Seroquel, because Seroquel actually has several clinical trials that show it has really good efficacy for anxiety.
And this conversation about the request to taper, that actually goes into December 9th of 2022, correct?
Yes.
And in her response to your indicating you were hesitant to taper, she indicates that she took the 5 milligrams of Valium and that she didn't have any left, and that she was afraid that she was going to take Ativan.
Correct.
And had you recommended to take Ativan as an alternative or in lieu of Valium?
No.
Were there any more communications on that day, December 9th of 2022?
Yes.
What were they?
Later that afternoon, Lindsay and her husband called.
Okay. And so did you, fair to say they called the clinic, leave a message, and then you called them back?
Yes.
And when you called them back, what was the nature of that conversation? What did you guys talk about?
Her symptoms, we discussed that the plan was to taper the Valium over the weekend, but they both agreed that Lindsay's symptoms were too acute. She's sleeping better, but still waking up with panic symptoms and intrusive thoughts, feels numb, has thoughts of SI, but no plan and no intent. I encouraged her to engage with women and infants in Rhode Island to complete an intake for a partial hospitalization program. But she was able to contract for safety over the phone with her, with the 3 of us on the phone, that she didn't have a plan, no intent, that she would reach out if needed. I did agree to continue the Valium until our next appointment, which was scheduled for 12/13. I prescribed it as 5 milligrams, but I advised her she could take a half tablet twice a day, so 2.5 milligrams twice a day.
Walk me through that. She had she had indicated to you that she wanted to slow the taper.
Yes.
And then you said no, that wasn't a good idea.
Right.
And then on the 9th, they call you and say that she doesn't want to taper. She wants to stay where she is, right?
I think it was that same day. The messages were earlier in the day, and then later in the afternoon, around, it's noted at 16:10, so 4:10 p.m., that she and her husband then called, advocating to stay on.
And in advocating to stay on the Valium, that she reported she's still waking up with panic symptoms and having intrusive thoughts, feeling numb, right?
Yes.
So in addition to agreeing to continue the Valium, did you make a recommendation about the Seroquel?
Continue the titration.
So when you say titration, what does that mean?
So I had recommended 100 on day 1, 200 day 2, 300 day 3, 400 day 4. This is the manufacturer recommended titration schedule to treat manic symptoms. Because again, I had shared with her, I think this is a mixed manic, hypomanic state. So that's what I was targeting.
Okay, and so as far as Seroquel goes, there's some guidance you get about Seroquel that's put out by the FDA, right?
Correct.
And it talks about dosage and administration for every drug, essentially, right?
Yes.
And as far as Seroquel goes, there is different recommended dosages or ranges for different mental illnesses that you're treating.
Correct.
So in this instance where bipolar is in your differential diagnosis and you're recommending titrate up to 400, is that consistent with the thought that you believe she had bipolar diagnosis?
Right. So I was thinking it was a mixed manic state or possible hypomanic state. A mixed manic state is when patient has symptoms of mania, like poor sleep, no loss of energy, but they also can feel depressed, numb, suicidal. It's sort of like it's a mixed state. It's a mixture of symptoms. That a mixed state presentation is clinically acute. It's unstable. So I really wanted to get the manic symptoms under control. I really wanted to get her to sleep.
And so going up slowly to 400 milligrams, what's the recommended dosage range for somebody with bipolar disorder of Seroquel?
For somebody, a manic presentation, you can titrate over days rather than weeks. You can actually go up to 800 milligrams.
And so even though you had previously indicated to them in your December 6th meeting that you were agreeable to discontinuing the Seroquel, based on our presentation in the days following, did you change your recommendation?
Correct.
And with the increased Seroquel that you had requested as of December 9th, she was reporting sleeping better, right?
Correct.
And that had been something that had been a recurring concern in your interactions with her, sleep?
Yes, my understanding was that she had been sleeping poorly since October.
And was there, when you say you were recommending partial hospitalization during that phone call, did you give a particular place in which you would recommend her to try to seek treatment?
Women and infants.
And that's in Rhode Island?
Rhode Island.
And are you familiar with whether they have particular perinatal or postpartum programs there?
They specialize.
After that call with the Clancys on December 9th, when was the next time you had contact with Lindsay?
December 9th was a Friday, so I believe it was Monday, December 12th.
No, people are able to send my chart messages all hours of the day, every day of the week, right?
Correct.
But in this instance, you did not receive any messages over the weekend?
No.
So the next my chart exchange was actually on December 12th of 2022, correct?
Correct.
Now, on December 12th, do you recall who initiated the contact via my chart?
Lindsay?
And at 1:59 p.m., she sent a message to you saying, I've been noticing on my Apple Watch that my heart rate has been fluctuating more than usual. It has been going from 56 to 136 within a matter of minutes. I'm wondering if this is a side effect of the Seroquel and if there's anything I should do about it. Thanks, Lindsay. Do you remember getting that message?
I do.
And again, at that point, as of December 12th, you had recommended the titration plan going up to 400, right?
Yes.
So by that Monday, where should she have been if she was following your instructions?
400 milligrams.
And did she report to you whether she took 400 milligrams of Seroquel?
She reported she was taking 200 milligrams.
Did she say why?
No.
But your recommendation was that she should have been up to 400 at that point.
At that point, yes.
As far as the concerns about the fluctuating heart rate, were you able to address that with her in a response?
Yes. I explained that medications like Seroquel can cause something called orthostatic hypotension, which is basically when you get up from sitting or standing, your blood pressure doesn't compensate in time, so it goes low and people can feel dizzy. I explained that the mechanism for that is alpha adrenergic blockade, so the alpha receptors that help us with like adrenaline. They're also part of the picture here with Seroquel. It's often accompanied by orthostatic tachycardia, meaning getting up from sitting to standing, your heart rate can fluctuate. I said both can be common in the first days of medication exposure or when the dose is being increased. It's generally benign, meaning non-harmful, and self-limiting, meaning it goes away on its own over time. I also advise it sometimes necessitates slowing a dose titration or dividing a dose into like 2 or 3 smaller doses.
Okay. And so with this response and trying to address these concerns, you're aware that she had spoken to the nurse that morning?
Correct.
And that she had expressed to the nurse a desire to get off the medications altogether?
Correct.
And what was your response to that concern that she had in the call to the nurse? What did you tell her?
I said, as long as you are aware of the risks, I don't think you've been on Seroquel long enough for it to have a positive benefit on your mood or anxiety. But if you have noticed benefit, the risk would be worsening of mood and anxiety upon stopping the medication. We also discussed tapering off the Valium, which I'm fine with, if you would like me to send along the taper schedule. Being off medication might help you see where you are at baseline, but I do think you are experiencing significant and severe symptoms of postpartum depression that needs to be treated. I acknowledge that medication alone is not always the best option for someone, but often it's part of the puzzle. Other treatments include counseling, support from others, exercise, healthy diet, yoga, and relaxation techniques. I know this has been brought to your attention several times, but I strongly, strongly recommend a partial hospitalization program so that you can get started on utilizing these treatment methods for relief.
And you were aware at this point, as of December 12th, that she had met with Letitia Dukes at least once, right?
At least once, yes.
She had been given referrals for CBT or cognitive behavioral therapy programs out in the community, in her community, right?
Yes.
There have been other recommendations for her to obtain a partial hospitalization program at that point.
Yes.
Now, anything about these exchanges that made you concerned that you had to kind of raise the level, meaning call her in for another meeting or make any sort of recommendations for inpatient hospitalization?
Not at this junction.
And why is that?
She wasn't reporting any acute safety concerns in these messages at this point.
It's just physical side effects.
Physical side effects, yes.
So the messages continued on December 12th, correct?
Correct.
So at 2:44, Lindsay messages you saying, "Thank you, Rebecca. It does seem to be orthostatic, and I'm glad to hear that it's benign and known side effect." And then she tells you a little bit more about the prior nights, right? So she says, "So the last 3 nights I've taken 2.5 milligrams of Valium and 200 of Seroquel. I have to say that I do like the way it makes me sleep very deeply and soundly for around 7 to 8 hours, but I don't like the way I feel in the morning and most of the day. Incredibly depressed and unmotivated to do anything at all. What would you recommend for tonight?" Is that the next message after you explained to her the side effects?
Yes.
Okay. So and for 10 p.m., you respond to her, don't you?
Yes.
And what did you recommend to address those concerns about incredibly depressed and unmotivated?
So at this juncture, I recommended at least continuing the 200 of Seroquel because at least now she's sleeping. So I felt like although I had recommended getting up to 400, we had gotten sufficient activation symptoms down. She was sleeping. And the 2.5 of Valium. I think I advise that we need to give time for Seroquel to work for your mood. Let's continue to accumulate good nights of sleep, as this can only be a good thing in terms of recovering and feeling better moving forward. I would say take them tonight, and we will discuss further at our visit tomorrow.
And you had a visit scheduled for December 13th, correct?
Correct.
The message continues on that day where at 7:17 p.m. where she says, okay, thank you. I need to make our visit virtual tomorrow. I will not be able to make it to the office. Can you please change it to that? Is that right?
Yes.
So after having met in person with her on December 6th, having had subsequent communications with her through the date of December 7th and kind of, again, changing a little bit about the medication plan and having further communication with her on December 9th and now December 12th, the plan was for her to again come in person on the 13th, correct?
That was my recommendation, yes.
Why did you recommend in person at that point?
This was somebody who was communicating with me every day, and I did feel that she had significant symptoms of depression, some mixed symptoms with mania, anxiety. I felt that her symptoms were severe and significant enough that I wanted to touch base with her weekly, and I wanted to see her in person. But again, I was okay with her doing virtual because I'd rather see her and lay eyes on her and try to treat her than not see her at all, if that would have made her just cancel the visit outright.
Because generally you do the same thing whether you're in person or virtual, right? As far as getting the history, going through symptoms, asking how they're feeling, doing the mental status exam, right?
Mm-hmm.
So you meet with her on December 13th at 10:30, correct?
Correct.
And now this is a virtual at her request.
Yes.
And do you revisit with her kind of the recent events and the timeline of the changes that you've gone through the MyChart messaging?
Yes, I structured my note as like a recent treatment timeline. So I put, 12/6, what had happened, 12/9, what had happened, and then I write update today, 12/13. That's sort of for me to like remember the treatment history that I've had with her so far.
Okay. Because while the MyChart messages are available to you, they might be in a different place, right? So they're not all contained within your same note.
Right. So I made note of, again, our visit on 12/6. I made note that she and her husband had called me on 12/9, and then I made note on the 13th. So I wasn't documenting all the MyChart messages, but just sort of my visit history with her and phone calls.
Okay. And so when you saw her in this virtual visit on December 13th, was she reporting improvement in her sleep?
Yes.
And how was she sleeping during that time period?
7 to 9 hours.
Okay. And that was holding at 200 on the Seroquel?
Correct.
And was she taking anything else daily?
Valium, 2.5, just once daily at night.
Okay. And while she reported sleeping better, she still had significant symptoms of depression, right?
Correct.
And what were the symptoms she articulated?
Hopelessness and, again, anhedonia, that feeling no pleasure, feeling numb.
Okay. And she also kind of complained of that racing heartbeat, and that's tachycardia, right?
Yep, the orthostatic tachycardia. So I recommended holding a bit longer at 200 milligrams. At this juncture, she had been on 200 milligrams for 4 nights. I wanted to continue it for a full 7 nights. And then we were still discussing whether to taper benzos, and our plan was to kind of slowly phase them out at that point. So we were going to decrease from 2.5 milligrams daily to 2 milligrams for 7 days, and then we were going to reassess at our next visit in a week. I also provided psychoeducation about behavioral activation, CBT techniques to utilize for depression. I also recommended postpartum.net for support groups, and I reiterated that she consider a partial hospitalization.
And again, during this telehealth visit, you have these conversations with her, but you also do your mental status exam. You make observations of her, right?
Yes.
Did you observe any signs of mania?
No.
Did you observe any signs of psychosis?
No.
Did she articulate to you any suicidal ideation?
She had endorsed that she had had thoughts of it on the Edinburgh over the previous weeks, that she sometimes had thoughts of harming herself, but not at that visit.
Okay. And would that have been something you'd follow up on? Would that statement from the Edinburgh? Or
Objection. Would that be something you'd follow up on?
No, I'll allow that.
So just to clarify, so again, the Edinburgh,
After coming from the witness judge, I'm sorry.
Objection overruled. Next question.
the Edinburgh is over the previous 7 days. So she had that thought sometimes when I asked her, are you currently having SI? It was no during the visit.
okay. And it just was the response sometimes.
Yes.
And so did you ask further in your interaction with her on that day on the 13th about whether she was experiencing suicidal ideation?
Yes.
Did she say she was?
No.
Did she indicate whether she had any plan or intent?
No.
And as far as intrusive thoughts, did she speak about intrusive thoughts during that meeting?
No.
Did she tell you she was having horrible thoughts?
No.
She had previously used that terminology in your MyChart exchanges, correct? At some point?
I do remember the intrusive thoughts that she would mention. Intrusive thoughts. I don't recall horrible thoughts.
Okay.
In the MyChart messages.
As far as the intrusive thoughts,
Mm-hmm.
were they things that you followed up on in your telehealth or in-person visits?
Mm-hmm.
And was she able to articulate to you?
Yes. Yes or no? Sorry.
Was she able to articulate to you what types of thoughts she was having?
Yes.
What were they?
Intrusive suicidal thoughts.
So thoughts of harming herself or just wanting to die?
Thoughts of wanting to die.
At any point, did she ever indicate to you thoughts of wanting to harm her children?
No.
So at the conclusion of this visit on December 13th, what was the plan?
The plan was to continue Seroquel 200 milligrams and Valium 2 milligrams.
Okay. And again, in this December 13th meeting, did you also indicate to her that she should engage with other services like support groups or partial hospitalization programs or CBT?
I did.
Do you recall whether you received any MyChart messages from her after that visit on the 13th?
I did.
So
I actually sent her a message on the 13th.
okay. So on the 13th, you meet with her at 10:30. At 2:27, you sent her a message. Why?
I wanted to send along some more ideas and information on what she could do to help herself feel better.
Because even though she was reporting sleeping better, she was still presenting with these depressed symptoms, correct?
Correct.
And so in the message you sent her on December 13th, it's actually a fairly lengthy message that talks a lot about cognitive behavioral therapy, right?
Yes.
And the benefits of it, and sends encouraging words.
Yes.
Does she respond to you on the 13th?
No.
The next contact you have with her, is that in a MyChart message on December 16th?
Yes.
And December 16th, 12:50 p.m.
Oh, no, I apologize. The next contact with her, there was a telephone call on December 15th.
Okay. Was it with you or was it with a nurse?
It was with me. and her husband and Lindsay.
Sorry about that. So December 15th at 3:53 p.m., you have a phone call with them. And what did they report to you in this phone call? What does Lindsay report?
They inform this has been the worst day for Lindsay, is having persistent intrusive thoughts of suicide, no active plan. But both Lindsay and Patrick agree that higher level of care may be necessary at this time. Discussed options, they state they are likely to go to MGH ED, as they have perinatal psychiatry as well as an inpatient psychiatric unit. Lindsay also deciding about McLean. This writer advised that they keep us posted and sign a ROI, release of information, so that we can communicate with treatment providers at higher level of care. Lindsay verbalized understanding and agreement.
So on this phone call that you had with them on 12/15, what prompted the recommendation that they go to the emergency department?
Again, they had described it as the worst day and was having persistent intrusive thoughts of suicide. And they were at the point where they were ready to get assessed for a higher level of care.
And was this different than some of the other communications that you've had with, or that you had with Lindsay Clancy over the course of the weeks?
I would say so.
Okay. And so you talked to them about the process of going to the emergency department and the potential for going to McLean for inpatient?
I recall advising them that if they were to go to their nearest ER, which would either be BI Plymouth or South Shore Health, the process would be that they would get evaluated. But if they were determined to need to go to a higher level of care or an inpatient psych, those facilities did not have inpatient psych units. So they may be sitting there waiting for a bed at any first opening in the state, which could be, up in, Amesbury or Newburyport. But that if they were to go somewhere like MGH has a unit called Blake 11, which is a psychiatry unit, and oftentimes they prioritize admissions from their own emergency department. MGH and McLean are also combined under the umbrella of what's now MGB. So sometimes if somebody presents to MGH ED and there's no beds at Blake 11, they might reach out to McLean and try to get them in to McLean.
So you communicated all of this information to them to kind of give them options on what the best course might be to get inpatient.
Yes, I summarized it in my note, but that's my recollection of the phone call.
Okay. And you're aware that that Ms. Clancy had been employed at Mass General as a labor and delivery nurse?
I was.
So they were familiar with that facility.
So I did ask, would you be comfortable with that?
And so then you were able to communicate with Lindsay via my chart that next day on December 16th, correct?
She reached out to me on December 16th via my chart, yes.
And she indicated to you on December 16th at 12:50 that she, after visiting the ER yesterday, I opted to remain outpatient and pursue the partial program at Women and Infants. And Women and Infants, that had been the program that you had previously recommended in Rhode Island, correct?
Correct.
She indicates, I'm waiting on a call back for them to schedule. In the meantime, I want to know how to proceed with my meds. Do you still recommend the 2 milligrams of Valium and 200 of Seroquel nightly? Again, it's making me sleep well, but still not improving my mood. So I will need a refill on those meds. Please let me know. So in this particular message, she indicates to you that she was waiting to schedule with Women and Infants, correct?
Correct.
Were you aware that prior to Letitia Dukes had already initiated the referral process for Women and Infants?
Yes.
And so on this particular message, she's kind of updating you, but also asking you if she should stay on the same track for her medication.
Yes.
And what was your response? So December 16th at 1:14.
I said, hi, Lindsay. I know Letitia may have called you yesterday about information about Women and Infants, so I hope you were able to connect with her. target dose for Seroquel treating depression is 300 milligrams. So we can increase it to 300 milligrams. If you are willing, yes, continue the Valium. Let me know what you think.
And why at this point did you recommend increasing now to the 300 after having recommended staying at 200 for the Seroquel?
The FDA recommended dose for treating depression, bipolar depression, with Seroquel is 300 milligrams.
So on December 16th, you continued to have messages with, my chart messages with Lindsay Clancy, correct?
Correct.
In any of, or do you know that she went to see her previous psychiatrist on that day, December 16th?
Yes.
And so in her messages later in the day at approximately 2:11 p.m., she indicates, I spoke with my original psychiatrist after my ER visit, and she recommended adding 25 milligrams of Lamictal to stabilize my mood. Is that something you would agree with? Had you ever talked with her about Lamictal before?
No.
Is it a drug that you kind of commonly recommend for people?
I do.
And was it something that you thought could be a good fit for this patient?
Yes.
And so in your response to her at 2:26 p.m., do you further talk about using it as a mood stabilizer?
Yes. I state absolutely lamotrigine works well for mood stabilization and depression. I talked to her about the side effects of it.
I'm fair to say those side effects are like rash and skin changes, fever.
Can we find out what the witness feels the side effects are rather than counsel?
Well, why don't we let the question be, what was she told? All right. I think that's the proper question. So why don't you ask what was told or what was said or messaged to the defendant?
Can you tell us what you messaged her the side effects were?
So I recommended it needs to be a slow titration, meaning titration, increasing the dose due to risk of SJS, which means Stevens-Johnson syndrome, which can be a very serious rash that somebody can get. There's a higher risk of it if somebody takes Lamictal, which is why the FDA recommends such a slow titration, 25 milligrams for 2 weeks, 50 milligrams for 2 weeks, 100 milligrams. You can't really go quick with it. But I also specified it can cause a benign rash as a side effect. So any skin changes you notice, you want to be sure are not accompanied by things like fever, malaise, pharyngitis, swollen lymph nodes. Also watch for a rash that is purpuric or tender. Benign rash would be spotty, non-confluent, non-tender, and no systemic features like fever. Otherwise, I find this medication to be quite well tolerated. Take with food to minimize any risk of GI, such as nausea. I will send this to your I can send this to your pharmacy along with the dose change in Seroquel. Any luck with hearing back from women and infants?
So the Lamictal, am I saying that correctly?
Lamictal.
Is that something that you would add to the Seroquel?
Yes.
And why would you add it to Seroquel?
They work differently. They have different mechanisms of action, and they can work well together.
And so at that point, on December 16th, do you recall kind of what the last version of the medication recommendations were?
From me?
Yeah, so at this point, you added a medication. So what was on the prescribed or recommended list for you, for her, as of December 16th?
So I asked her if she needed me to send along the lamotrigine, and she said that she had her psychiatrist send it along.
Okay, so, but as far as now what you know to be the medications that she's been advised to take, what are they at this point, December 16th?
Lamotrigine, 25 milligrams, Seroquel, 300 milligrams, and Valium, 2 milligrams.
And the Valium, is that still a daily recommendation?
Yes.
At the end of that message that you just read, you asked her if there was any luck with hearing back from women and infants, correct?
Correct.
Did she respond to you in a message about what was happening with the women and infants? The next message at 2:33?
In 2:33, she said, unfortunately missed the call this morning from women and infants, but I did request them to call back. I'm hoping they do so today.
Okay. And you said that you'd also learned in this exchange that her other psychiatrist had already called in the lamotrigine prescription.
Correct.
And then, did you have any further communication with her on 12/16?
I said, okay, sounds good. I hope so as well. And that was it.
When's the next time you spoke with her?
12/16 was a Friday, so I spoke to her on Monday, December 19th.
And again, did you speak with her via the MyChart messaging, or did you speak to her on the phone?
MyChart messaging.
And were you aware that on December 19th, she had another appointment scheduled with Letitia Dukes for that morning?
Yes.
And in your communications with her via MyChart, they started at 11:04 a.m. on December 19th?
Yes.
And does she indicate to you in that message that she is starting with women and infants partial hospitalization tomorrow, meaning the 20th?
Yes.
And that she's concerned because she has an appointment scheduled with you already, and she's asking what she should do about that, correct?
Correct.
And what was your response to her?
So she has an appointment, but should be in the program. Should I call and cancel or reschedule because she thought the program would be starting her medication? I said, I'm so glad you were able to get into the program this week. That's great. So feel free to call and reschedule. The only issue is that I am on vacation next week, so it might be 2 weeks out that we touch base again. If that's okay with you, let me know what you think.
Okay. And her response at 1:24 that says, I think since I'll be followed by women and infants, that 2 weeks out will be okay. My only concern is potentially needing more Valium before that. I'm trying my best not to take it at night, but have still been taking 2 milligrams every other night. Can we refill that just in case I continue to need it, right?
Right.
So at that point, when she sends that message saying she needs the new prescription for Valium, was that in line with the recommendations you made for a taper of Valium?
I had recommended that she take it daily.
Okay. And so in this, she indicates to you that she's trying not to take it at night, but taking it every other night.
Mm-hmm. Correct.
And on December 19th, you respond, sure, no problem. When will you be out of Valium? And she responds, I'll run out tonight. And then you agree to send in a refill.
Yes, I wanted to make sure she had an appointment rescheduled with me, and then I would refill enough of the Valium to get to that next appointment.
And so did you refill the prescription based on what she reported she was taking, or what your recommendation was that she take of the Valium?
What my recommendation was that she take.
And so do you recall receiving a message on December 20th via MyChart from Lindsay?
I do.
And she reported to you that she had been discharged from women and infants that day, correct?
Correct.
And that they recommended she find help getting off the Seroquel, and that she was indicating that she'd like to taper the Seroquel.
Yes.
Did you respond that day or the next day?
The next day.
Okay.
Her message came in at 8:05 p.m., so I responded the next morning.
Okay, 10:57?
Yes.
And what were your thoughts about her report that she was discharged and the recommendation for tapering the Seroquel, or getting off the Seroquel, I should say?
I said, I'm not opposed to that. However, I'm concerned she discharged you, as I do feel you could benefit from the groups and added support separate even from medication changes. In fact, if we're not going the medication route, I think groups and therapy are the treatment needed, as I feel the intrusive thoughts you've been having are nonetheless concerning, and I know they've caused you considerable distress. I'm also on vacation next week, so I'm hesitant to start a taper when I am not available to you for questions and concerns. Again, I'm open to starting a taper, but I want to be available to you as it happens. You mentioned you are connected to your previous psychiatrist. Would that be someone to consult as well?
And so when you sent this message at 10:57, were you opposed to the idea of tapering the Seroquel?
I understood that it was helping her to sleep, and I also understood that she felt as though she was still depressed, and she wanted to come off of it.
And in this correspondence back and forth on the 21st, was there any conversation about the lamotrigine and whether she took it as a mood stabilizer?
No.
As far as coming off medication, was that something that you thought might be a good option for her?
As I had expressed to her, I was hesitant. It could be done, but she would need a lot of what I would recommend to be group support, therapy, other types of treatment.
At that point, based on your interactions with her through the clinic, through all the messages, through the meetings that you've had, were you aware of whether she was getting any other support, like groups, other than Letitia Dukes and yourself?
No.
And this partial...
I apologize. Is she aware or no, she wasn't? She just said
Okay,
no.
sure. If you could just,
Are you aware of whether she was?
I was aware it was recommended. I was not aware that she was interacting with any groups.
And the South Shore Perinatal Behavioral Program, you have groups that are offered through the clinic, correct?
At that time, we did, yes.
And if she was attending groups through the clinic, would that be something that you would have access to or be noted in her records?
Yes.
And as far as your communications with her, did she report to you that she was attending any sort of groups or therapy at other places in the community?
No.
The only person you were aware of that she was communicating with was her previous psychiatrist, correct?
Correct.
And that's why you made that recommendation to consult with her?
Correct.
And what's your concern, or what was your concern for not being available to her while you were on vacation with a taper?
I wanted to be there to evaluate if the taper was going okay, if she was suddenly having a hard time sleeping again. So maybe I could recommend that we go back up, or, just to reassure her, to be there for her while this was happening.
In your prior communications with her, she was very communicative with you about symptoms, about issues, about concerns, correct?
Correct.
And if you're on vacation, are you responding to my chat messages?
No. There would be someone that would respond. It would have been my nurse, and they would have consulted with the two other, and Julie, believe her last day was the 22nd, but they would have consulted with the other NP there, but I would not be available, no.
And you were invested in this patient's care, weren't you?
Yes.
So on December 21st, after you made that recommendation that she not start the taper while you weren't available or consult with her other psychiatrist, did you get a response from her at 3:57?
On December 21st?
Yes.
I see 3:47.
Oh, I'm sorry. That's what I meant to say.
Okay.
So 3:47, she responds back to you, correct? And gives you some more information about the women and infants recommendation?
Yes.
And it reads, the psychiatrist at Women and Infants recommended a more general mental health, PHP, partial hospitalization program, right?
Correct.
Such as the one at McLean, which I'm open to. I'm also looking to schedule with a CBT therapist in Duxbury. My other therapist does have appointments this and next week, so I can follow up with her too. How would you recommend starting the taper? I will need smaller pills, as the ones I have now are all 300 milligrams. Right? That's her response.
Yes, she says her other psychiatrist does have appointments.
And in the meantime, she had also sent an email to the clinic. You aware?
I'm not aware.
Okay. Do you know if she spoke with the nurse at some point on the 21st?
Yes, I asked my nurse to call to, again, go over the risks of tapering, which could include worsening of mood, worsening of sleep, verify that this was really something she wanted to move forward with, remind her that I wouldn't be there.
Okay. And on December 21st, 2022 at 4:26 p.m., you respond to her in the My Chart message, right?
Right.
And you had expressed reluctance for the taper, but ultimately, did you provide her a plan for taper?
Right. I said, I know Nicole reached out to you and she relayed that you would like to proceed with the taper. I'm sending as 100 milligram tablets, 200 milligrams, 2 tablets for 4 nights, 100 milligrams, 1 tablet for 4 nights, 50 milligram tabs, half tablets times 4 nights, then off. Let me know if any issues.
And is that a standard or slow taper off of Seroquel being at a 300 milligram dose?
Considering the fact that she had only been taking it for a few weeks, yes. If she had been on it for months, I would have done a slower taper.
And in addition to giving her that plan, you also had the nurse provide her with some information about DBT groups, correct?
Correct.
And what's DBT?
Dialectical behavioral therapy.
And how's that different from cognitive behavioral therapy?
Dialectical behavioral therapy, there's certain tenets to it, like emotion regulation, distress tolerance, interpersonal communication. There's a lot of skills to it. It's a very skills-based treatment. So we had recommended that as an additional support.
And the next time you had contact with the Clancys, when was that? After December 21st?
I believe that was my last contact with Lindsay.
Okay. As far as the perinatal behavioral health clinic at South Shore, you're aware that on December 30th, Patrick Clancy called in about his wife.
Correct.
And that he spoke to a nurse, Katrina Melanson.
Yes.
And the record reflects that he reported that she was safe, right? But she'd like to go to McLean.
I do recall that.
And he was advised to take her directly to the emergency department. You can't just go there to McLean, right?
Right.
In your experience.
In my experience.
And that he said he didn't want to waste a day in the ED. Is that your recollection of the record?
That is my recollection of the record.
And that he was looking just to get the bed that was offered the last time on December 15th.
Yes.
And it's fair to say that that's not how the process works?
They do not hold beds for that length of time.
Okay. And so then he was advised to take her to the emergency department or call 911?
Correct.
And was that the last contact that the South Shore Perinatal Behavioral Health Clinic had with Lindsay Clancy?
Yes.
You were never advised or got any messages from her after she went to McLean, did you?
No. We did check.
Okay. The answer is no. Go ahead.
Did you learn anything about her course of treatment at McLean after the fact?
We had been wondering if she would come back to us. We did review the Mass PMP, which is sort of a log of controlled scripts, and we saw that she had medications filled from her previous psychiatrist, Dr. Tufts.
And that would have been...
No object to move to strike. It's not responsive to the question about McLean. She's now talking about...
Overall.
So the Mass PMP, what is that?
It is a database that shows when patients fill controlled scripts such as benzodiazepines.
And as a prescriber that has a DA license, you're able to review that information for any patient?
Yes.
And so after the 30th, when the call came in about going to McLean, you're able to identify that she was prescribed additional medicines by a different prescriber?
Yes.
And she never came back to the clinic?
Correct.
During all of your interactions with Lindsay Clancy, did she always present with clear linear thinking?
Yes.
Was she able to express to you her concerns and ask appropriate questions when necessary?
Yes.
And was she able to advocate for herself and express that she had some knowledge base about some of these medications?
Yes.
And at no point during the time that she was your patient or that she was at the clinic, did she ever indicate that she was had a plan to kill herself or harm her children? Did she?
No.
Thank you. There's nothing further.
All right. Counsel, can I see your sidebar? So I'm going to excuse you till around 2 o'clock. Same instructions, the research, talking about this case. I hope everybody has a nice little break here. We'll see you back here right around 2 o'clock. Okay?
Court, all rise. Judge, notebooks, place on your chair, please. This way.
That's from Angela, so just so you know, I might have to do something because they wanted that repeated.
Okay.
Doing the process.
All right. So we'll be in recess on this matter till around 2 o'clock. Okay?
But she just, one night she said, do you mind? She started it by saying, I'm not mad or anything, but do you mind sleeping in the basement? And letting me just sleep in our room with Callan. And then you can take the monitors down in the basement. And if Cora and Dawson get up, you can get up with them. She said, I've just been having a lot of trouble sleeping. And I'm hoping that, like, if there's less in and out, then there'll be less disruption.
Okay. Had you noticed prior to her telling you this that she was up a lot or having trouble sleeping, like physically seeing her awake?
No, not that I recall.
And did you in fact start sleeping in the basement for a period of time?
I think I did it for like 2 nights, and then she actually went down in the basement.
Okay, so then you went back up to your bedroom to sleep, is that correct?
Yeah.
And how long did Lindsay sleep in the basement for after that?
Maybe a couple weeks.
And so during that time frame, was she telling you that she was still having trouble sleeping?
Yes.
But you weren't actually down there watching her sleep. You're getting this information from her, correct?
Correct.
Were you aware that out of the Zoloft prescription she was given, she only took 7 pills?
No.
After you had the conversation with Lindsay where she said she was going to double the dose of Zoloft, did you notice any difference in her demeanor or behavior?
I would say yes. I don't know if I connected it with the doubling of her Zoloft, but over that period of time, she just kept getting worse and worse.
And what period of time was that? What month are we in?
Mid-October to the end of December.
Okay, so she got the prescription in September, started taking it in October, took 7 pills, but was having difficulty in December. Is that what you're saying?
Yes.
From this medication?
Yep. Well, I don't know which medication it was from, but yeah.
Okay. At some point in time, did Lindsay switch providers?
Yes.
And why did she do that?
Because whatever she was doing with Jennifer Tufts, it wasn't working. She was only getting worse. And she thought that it would be better if she worked with, I guess, more of like a perinatal psychiatrist.
And did she get a referral or a recommendation of where to go?
I think so, yeah.
Do you know who gave her that recommendation?
It might have been my mother.
And your mother's a nurse at South Shore Hospital, correct?
Yeah.
Does she also do labor and delivery work?
Yes.
Okay. And so do you know which provider or which office she recommended?
Yeah, her name is Julie Paul.
And was she at the South Shore Perinatal Clinic?
Something like that, yeah.
Okay. And do you know when that was?
I don't know the dates on that.
Do you recall saying previously that it was towards the end of November?
Yeah, that sounds accurate, yeah.
Okay. And you said she initially saw someone named Julie Paul, is that correct?
Correct.
Okay. And do you know how long she saw Julie Paul at that facility?
I think it was only 4 or 5 days.
And were you aware that Julie Paul left that office?
Yes.
And do you know who Lindsay saw after Julie Paul?
Rebecca Gelata.
And was Rebecca Gelata a nurse practitioner?
Yes.
Were you aware that she also saw a licensed social worker therapist named Letitia Dukes while she was at the South Shore Perinatal Clinic?
I don't recall Letitia Dukes, but it's possible.
So Lindsay never told you that she had therapy sessions with a person named Letitia Dukes during that time frame?
I don't remember any therapy sessions now.
Okay. After switching to Julie Paul and then Rebecca Gelata, did Lindsay start coming home with different prescription bottles?
Yes.
Okay. And were some of these medications that she came home with, were some of them during the time she was with Dr. Tufts?
I think some of them were, yeah,
And some of them were while she was with Julie Paul, is that correct?
correct.
And then some while she was with nurse practitioner Gelada, is that correct?
Yes.
Okay. And would it be accurate to state that you provided the district attorney's office with a printout from CVS Pharmacy of all the prescriptions that were filled for Lindsay from September through January, September 2022 through January of 2023?
Yes.
Any objection?
No, of course not.
I'd ask for it to be admitted as
Sure,
one.
yeah. In members of the jury, one of the things I forgot to tell you is anything that's entered as an exhibit, you'll have with you in the deliberating room when you're deliberating. So you'll have a chance to go over that as well. So you'll have anything that's marked as an exhibit. Okay? Thank you.
Now, while she was taking these medications, the various pills, were you always with her, watching and monitoring exactly what she took?
Not always, no.
Sometimes you'd see it, sometimes you wouldn't.
Yeah.
Directing your attention to February 6th, 2023, did you go to the district attorney's office and, or have your attorney go there and provide a bag of prescription medication that had belonged to Lindsay?
Yeah. I think the police took a bag of prescription medications that night, the night my kids passed away.
Mm-hmm.
And then there was a bag that I had in my truck that I was supposed to, nurse practitioner Gelada said you can bring them to like a police station. They get rid of them for you. But I never got around to it.
And where had you stored those in your truck?
In the center console. It's like underneath the center console that opens.
You have one of those center consoles that open up, but then there's another larger
Correct.
compartment below it?
Yeah.
So was it your plan to bring these to a location where they could be properly disposed?
Yeah, I didn't want to just throw them in the trash, so.
And these were all medications that had been prescribed in the past to Lindsay, but she was no longer taking, correct?
Right.
Your Honor, I don't think I have any objection to any of their exhibits, so
Okay.
she doesn't have to keep showing it to me, that's
All right.
fine.
So I'll assume if you do have an objection, just
Sure.
rise, let me know. Okay, thank you.
So for the record, a bag here with 9 pill bottles as exhibit 2, please.
Thank you.
And so looking in exhibit 2, we have the Zoloft that was prescribed by Dr. Tufts and filled on September 15th, 2022. And I think I asked you earlier, you weren't aware that only 7 pills were taken out of this, correct?
That's correct.
Okay. And then there's another prescription in here for Ativan that was filled on October 26, 2022. Were you aware that only 6 pills were taken out of that bottle?
Can you say the date again?
October 26, 2022.
And how many did it start with?
Let's see. Um, 30 pills.
Okay. I mean, I don't have those exact numbers on how many she took, but there were adjustments made on the dosage of the Ativan.
Mhm.
So that aligns with with
But
what
the question was, were you aware that only 6 pills were taken out of this prescription?
happened. No, but I think the context is important.
Okay. Were you aware that there was a prescription for buspirone or Buspar filled on October 26, 2022, in which only 2 pills were taken out of the 30 that were prescribed?
I found out about the Buspar later, and I didn't know about the number of pills taken.
And then were you aware that there was a prescription for hydroxynine, prescription filled on October 26, 2022 for 30 pills, and that only 3 pills were taken out of this bottle?
Which
Hydroxynine?
Yeah, what is that?
I believe it's in some type of, similar to an antihistamine, like Benadryl or something like that.
Oh, okay. I don't really recall much about that drug.
Okay. And were you aware in this bag there was another prescription for Buspar that was filled on November 9th, 2022, 30 pills prescribed, and no pills were taken out of this bottle? Were you aware of that?
I wasn't keeping track of the number of pills taken out of each bottle,
Okay.
so.
And then just ask you about one more, the trazodone prescribed on November 16th, 2022 by a doctor from South Shore Hospital, 30 pills. Were you aware that only 7.5 pills were taken out of this prescription?
No.
So there were a lot of pills prescribed, but not a lot of pills taken, correct?
Is that comprehensive of all the pills that were prescribed?
These are the pills that you brought into the police station. So out of these,
Out of those, yeah, it's possible that not a lot were taken.
Quick pause, y'all. That's a lot of pills. That's way too many pills for anybody to be taking. It's just totally ridiculous. And that's what they do, is throw pills at the problem. Unfortunately, that's their answer for everything. You know, never mind the natural remedies and that type of thing. So it's pretty sad. It's how it works in society these days.
do you recall what was the most amount of pills prescribed? I guess I could ask this better. What was the maximum number of medications she was on at any one time?
I want to say 3 or 4.
Okay. Would it surprise you to know that she, at any given time, the most she was prescribed was 3, but most of the time it was 2 medications that she was prescribed at any given time?
It wouldn't be terribly surprising, no.
Now, on November 16th, 2022, did Lindsay visit South Shore Hospital?
Yes.
Okay. And why did she go to the South Shore Hospital that day?
I believe that day it was because she basically went 48 hours without sleeping.
And was she having heart palpitations?
I think so, yeah.
Were you aware that she had taken a weed gummy that day?
I don't recall.
And are you aware that she didn't tell medical staff at the hospital when describing her symptoms and her medication that she left out that she had used marijuana?
I wasn't with her, so I don't know what she talked about at the hospital.
So she drove herself to the hospital?
She did.
And she drove herself home from the hospital then, is that correct? Now, during this time frame between September and November of 2022, are you still participating in activities as a family?
Between November and December?
Between September and November?
Yeah.
Okay. And what types of things were you doing?
We celebrated Halloween. I don't really remember what else, but I think we were doing things regularly.
Do you recall going to an event with food trucks?
Yeah.
And do you recall going to an event in November where there were trains to ride with the kids?
Yeah.
So we have the photo from the food truck event, this is exhibit 3.
Angel, what's your language, young lady?
3 and 4 somewhere. Can I publish?
You may.
So exhibit 3 is this Lindsay, Cora, and Callan at that event.
Yeah.
And exhibit 4, just Lindsay with all 3 kids at that event in November.
Yeah.
Awesome, Michelle. I'm glad you're still here. Say hello to my daughter. That's unique.
Did you have
Angel is
plans
my
for
daughter.
Thanksgiving that year?
Yeah.
What were your plans?
Angel, say hello to Michelle. Cases and conversation.
I believe the order was we went
Subscribe to her channel, please.
Wallingford,
Thank
where her
you.
parents lived, and the week before, and then the week after, we went to my sister's house,
And where did your sister live? What town?
South Hamilton.
And that was a week after Thanksgiving, is that right, correct?
I think so. Yeah. Yeah, it was.
And is this a photo from Thanksgiving at your sister's house?
Yes.
I could have this photo marked as exhibit 5, I believe.
All right, that may be marked.
5.
We are all besties now. We love each other.
Showing you what's been marked. Exhibit 5. Is this Lindsay here on the left?
Yes.
And are those your sisters in the photo with her?
That's one of my sisters and my sister-in-law.
Okay. And have they coordinated outfits for the day? The shirts?
Yeah, I think my sister did.
What was Lindsay's demeanor that day?
She was in rough shape.
Rough shape?
Yeah.
How so?
She wasn't talking much. She had low energy. She was really depressed. I just remember when she showed up, my sister-in-law gave her a big hug.
And she was able to get through dinner, eat dinner with everyone?
Yeah.
Okay. She interacted with people, is that correct?
I would say very little, but to some degree, sure.
And she took care of the kids with you while she was there?
We both took care of the kids together.
You mentioned earlier that your wedding anniversary is in December, is that correct?
Yeah.
Do you recall going out for your anniversary on December 3rd, 2022, going into Boston?
No, we didn't go out.
You don't recall arranging for a massage for Lindsay and then going to the Omni Parker house and going out to dinner that night?
No, December 3rd, 2022, we stayed home.
You stayed home, okay. Showing you a photo of you and Lindsay. Do you recognize this photo?
Yeah.
When was that taken?
I'm not really sure.
It wasn't taken on December 3rd when you were out celebrating your anniversary?
In 2022?
Yes.
No. No, we wanted to go out, but we canceled because she wasn't feeling well. So we stayed home. We got takeout.
Okay. Did you also, on November 26th, 2022, go out as a family to get a Christmas tree?
Yes. Well, probably. I don't know. But yeah, around that time, yes.
Okay. Showing you 2 photos. Are these from that day when you got the Christmas tree?
Yeah, that looks accurate.
You could have the first photo of all 5. 6. And then the second one is Exhibit 7. Exhibit 7. Showing you Exhibit 6. This is all of you at the tree farm.
Yeah.
And Exhibit 7, those are the kids.
Yes.
Around December 6th, 2022, did Lindsay tell you she was starting a new medication?
I don't remember specifically.
Is it that you don't remember the date or you don't remember her starting a new medication?
I'm not sure.
Do you remember Lindsay telling you at some point she was starting the medication Seroquel?
Yes.
Do you remember around what time frame that was?
I thought it was before December 6th.
Okay. And do you recall how she was physically after starting the Seroquel?
Awful.
How so?
That was really where her big spiral started. She started to lose a lot of weight, and she became very depressed, and she was having a really hard time.
And did she describe to you some thoughts or feelings that she was having at that time?
Yeah, she started to say she was suicidal.
And was that in December of 2022?
I think so, yeah.
And when she told you she was suicidal, did you ask her if she had a plan on how to kill herself?
Yes.
And what was her response?
She said no.
And did she ever mention a specific way or plan she had to kill herself to you?
No.
And at some point in time, did she tell you that this was the first time she had suicidal thoughts?
I don't know if she mentioned it was the first time or not. I just remember her saying she had them.
Had you ever heard her say that to you before, that she was having suicidal thoughts?
No.
Did you own at that time a Surface Pro, a type of tablet that works as a laptop?
Yeah.
And who had access to that laptop?
We both did.
Okay. You and Lindsay?
Yeah.
And going back to August 22nd, 2022, did you click on a link on that Surface Pro that was titled Methods of Suicide?
Not that I recall.
And August 22nd, 2022, that was before Lindsay had been on any medications, as far as you know, correct?
Correct.
Going back to December, she's told you that she's having these thoughts. What's your reaction when she tells you that she's having these suicidal thoughts?
I just wanted to support her. I asked those questions back to her, and her mother was coming up pretty regularly anyways, so we let them know, and we just try to be supportive.
Did she also tell you at that time, at the beginning of December, that she was having some other intrusive thoughts?
Yeah.
Is that how she described them or how you described them, intrusive thoughts?
I would say both.
Okay. And when she told you that she was having intrusive thoughts, did you ask her what they were?
Yeah.
And what was her response?
She described thoughts of hurting the kids or them having some sort of ailment. So like she was very worried that Cora had, whenever she had a stomach ache, she became overly worried that she was, like had like a liver problem or something much more dramatic than it was.
Okay. But going back to that first part, she said she had thoughts of harming the kids. Is that correct?
Yeah.
And did she tell you whether or not she had specific thoughts of how she would harm the kids?
No.
And she didn't describe that as hearing this external voice telling her to harm the kids, correct?
Correct.
She told you she was having intrusive thoughts herself of harming the children, correct?
Correct.
And did you ask her how she was going to harm the kids?
I didn't ask it in that way. It was the same thing. I said, do you have a plan and is it disturbing to you? And she said no, and then she said yes. And
let me go back for a minute there. You said, do you have a plan? And she said no. What was the second question? Second part of the question?
I said, do you find it disturbing?
Okay.
And she said yes. And she described it as really the way she was describing it as something that might happen to the kids.
So it was more something might happen than she might do something. Is that correct?
Yeah.
And did she tell you how long she had those thoughts for?
She didn't give a duration.
And how many times did she tell you this, that she had thoughts of harming the kids?
A couple times.
And was that a couple times over the course of a night or two in December?
Yeah.
And as a result of her telling you this, that she had thoughts of harming the kids, what did you do?
Her parents came up, and I think I asked her at some point, do you feel like you need to be kept away from them? And she said no. And then, it was very confusing because a minute later she was making them lunch or playing with them or, getting them ready for bed or whatever it was.
So it was confusing in that she wasn't physically harming them at the time, but had these thoughts. Is that what you're saying?
Right. I never saw Lindsay harm the kids.
And did you also, as a result of these statements, suggest an appointment with nurse practitioner Gelada?
It wasn't as a result of these statements. That appointment was set up because we were at her parents' house in Wallingford for Thanksgiving, and she just described how she was feeling on the medication, and she felt that she was addicted to them.
Was that the benzodiazepines that she thought she was addicted to?
Primarily, and then she was taking Seroquel at the same time, and she might have been taking Trazodone or Remeron. I'm not sure.
Okay. Do you recall testifying previously that I called her parents to come up to?
Pause. Keeping an eye on the courtroom. They're not back from lunch yet. So when they get back live, we'll go back inside the courtroom. Until then, keep listening to this guy here.
To stay with us. And I told her that I asked her who her doctor was because I was very concerned at this point. She was prescribed 10 different medications in just over 2 months. So it didn't make sense to me. And then you said, so after her parents came up, she said, I have a remote meeting with Rebecca Gelada. And you said, no, it has to be in person.
Yeah, I felt like it had to be in person because I just felt like there was a disconnect. I felt like we could figure it out. Whatever was going on. Mm-hmm. So it seemed like most of her telehealth appointments were pretty quick, and there just wasn't like a lot of attention. And
were you present for these telehealth visits?
Only a few of them, okay. And they were after that meeting with Gelada.
Okay. And that appointment in person with Gelada was December 6th, 2022. Is that correct?
That sounds correct.
So the thought of harming the kids was after Thanksgiving, but before December 6th. Is that correct?
That sounds correct.
Were you concerned for the kids' safety at that time?
No, I wasn't,
And why not?
because she wasn't showing any intention of harming the kids.
And she told you she didn't have a plan. Is that correct?
Correct.
Now, directing your attention to December 15th, 2022, did Lindsay go to Mass General Hospital to the emergency department that day?
Yeah.
Okay, and why was that?
I remember the reasoning being she told her dad that she wanted to commit suicide, and then she said to me, I told my dad I want to die, and it didn't bother me at all.
And as a result of those statements, you brought her, or did she bring herself to Mass General?
I think I brought her that time.
And at Mass General, she saw medical staff, correct?
Yeah.
Okay. And did they recommend to her some type of admission to McLean Hospital?
I remember there was one doctor who was in favor of that, and there were two others who were more in favor of a day program.
Okay. And did they give you information about a specific day program?
Yeah, it was women and infants in Providence.
And at that time, when Lindsay was saying that she was suicidal, was she asked if she had a plan?
By the doctors.
Or by you?
I was always checking in with her, and she never told me that she had a plan. I'm not sure what the doctors asked her.
Okay. And after being at Mass General on December 15th, did she go to Women and Infants Hospital in Rhode Island to attempt to get into their postpartum program?
She was already in. She went in as scheduled.
Okay. And but she didn't remain in, correct? She was just there for a day?
Correct.
Okay. And did she go by herself? Did you go with her?
I dropped her off, and then I took Dawson skiing.
Okay. And at some point in time, did Lindsay reach out to you to say she wasn't staying at the program and to come pick her up?
She actually said that the providers at that program suggested to her that she call me and have her come get picked up, and then that I should go in and meet with the providers.
Okay. And then after you picked her up, she was no longer in the program at that point, correct? At Rhode Island Women and Children's, right?
Well, we discussed it with the doctors, and their recommendation was that the program wasn't right for her.
Right. And so you guys returned home, is that correct?
Yes.
Okay. And during this time frame in December, Lindsay's still working out at the Kingsbury Club, correct?
That might be true. I don't recall exactly, but yeah.
Okay. Do you recall her going to the Kingsbury Club on December 6th, 13th, 16th, 17th, or 18th?
I mean, I believe that can be true. Yeah, I don't recall those exact dates, but yeah.
At this time when she's saying that she's feeling suicidal, she's telling you she doesn't have a plan, correct?
Mm.
She's no longer saying she has any thoughts of harming the children, correct?
Correct.
She's still bringing the children to doctor's appointments during that time, right?
All right. Jurors enter. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the 18 jurors.
All right, thank you, Madam Clerk. Mr. Reddington?
Thank you, Judge. Good afternoon.
Good afternoon.
Your Honor, just a couple of housekeeping matters. I have the medical records from Women and Infants Hospital. I thought I offered that as an exhibit, but it's only marked for ID, so can I offer that now?
Call with any objection?
I have that we did mark them as exhibit 220.
Yeah, I don't, this just says Exhibit F though. That's why I usually mess up on those things.
There was another smaller packet that's not in a binder that council offered yesterday that's been marked as exhibit 220.
There, it's up there.
Okay. All right, why don't we keep that marked for identification? If for some reason there's something different between Exhibit 220 and the identification, we could enter it. Okay. All right. If you need to offer anything additional, just let me know.
Great, thank you. Thank you, Don. The other thing, Your Honor, that what I would ask is that there has been a lot of reference to the Diagnostic Statistical Manual 5 TR, especially as it relates to bipolar and related disorders. There's not an awful lot, but there's like probably 15 pages of single space typing, and it's really hard for people to absorb it. I'd like to offer that section of the DSM just as an exhibit, so if somebody wanted to look at it, they could.
I would object. We have witnesses to testify about that.
All right. All right. Why don't we mark that for identification? I guess
that's my book, though. I need it.
Oh, I don't want to take away your book. Why don't we can readdress that?
Okay, sure.
In regards to that, and if we're going to do it, it would just be portions of the.
Yes, it would only be that one section.
But we'll see. Well, I'll give the Commonwealth the opportunity to be heard.
Okay, thank you. So you, in the course of your employment at the South Shore Health, is it?
Yes.
How many times did Lindsay meet with you?
Meet with me was 3.
And how many times did she meet with, does that include medical?
Yes, I saw her twice, telehealth once in person.
And do you know how many times that, you know that she had a psychiatrist that had been treating her since end of September, early October, right?
I knew that she had a psychiatrist that treated her in September.
And who was that?
Dr. Tufts.
And did you know that she continued to see Dr. Tufts through October, November, December, the same time that she was reaching out to you guys for help too?
I was aware she took the Zoloft in October. I was not aware she was still seeing Dr. Tufts in November. And I knew she called her in December.
You would agree with me that young woman came to you people for help, right?
Yes.
Okay. And she was very, very forthright. In other words, if you wanted her to sign a HIPAA form, she'd sign it, right?
Right.
And she would answer your questions to your perspective in an honest fashion.
Yes.
She didn't really hide anything.
Nope.
She told you all about the medications that she had been on and her fears and concerns about the medications, right?
Correct.
She described to you, as District Attorney brought out, what she felt her symptomology was, including suicidal ideation, worrying about suicide, feeling heavy, lethargic, you can't get out of bed, all of that stuff, right? Correct?
Correct.
And one of the things that you had left us with towards the end of your testimony is the fact that you were very willing, if you will, to work in tandem with other providers. In other words, you were concerned about being able to get information from other providers that had been dealing with her, treating her, right?
I'm not sure I understand the question.
Did you talk to Tufts?
No.
Did you ever get access to Tufts' medical records?
No.
Do you know how many times she saw Dr. Tufts?
I do not.
Would it surprise you if I told you that she saw Dr. Tufts 14 times in the time frame of October or the end of September October, November, December, and then January, 4 months.
Yes.
And that's 14 times plus the 3 that she saw you. Is that right?
Yes.
So that's 17 times that this young lady had access to healthcare providers for her mental health issues, correct?
Correct.
And that would be within a compressed period of time. I know it's the last week, I believe, in September, but October, November, December, and then January, right?
Yes.
And during that period of time, you're aware that she was provided many, many, many prescriptions for antipsychotics, selective serotonin reuptake inhibitors, benzodiazepines, all of that, right?
I'm aware she was prescribed other medications.
She was what?
Prescribed other medications.
Did you ask what other medications there were?
Yes.
And did she tell you?
Yes.
Did she tell you who prescribed them?
Yes.
It's pretty easy to get a list from CVS, right?
Yes.
And did you have any difficulty determining who was providing the prescriptions for all of these medications?
No.
And did you know that, in fact, it was Jennifer Tufts that prescribed the sertraline, September 15th of 2022, 30 count, 25 milligrams, was Jennifer Tufts. You knew that?
I did.
You know that Jennifer Tufts on October 21st, 7 count of lorazepam. You know that?
I did.
And 5 days later, Jennifer Tufts prescribed on October 26th hydroxyzine, 25 milligrams with a 30 count. Did you know that?
I did not know that.
Did you know that on the same day, Tufts prescribed 30 count of lorazepam? Did you know that?
I would have known that, yes.
I was in-
Checking the PMP for controlled substances, yes.
Did you recall that you checked with it?
Yes.
When you download, do you download that information and kind of put it in the file, move the file?
No.
So is this your memory that you believe that you checked with PMP?
I do routinely check the PMP.
You might routinely check, but did you check?
Yes. Yes, I did.
Don't download it, you don't keep it with the medical records, right?
It's a box you can click in the medical record and you can check that you reviewed it.
Okay. Is it in your medical record that you reviewed it?
I'm not sure how it would have gotten printed out. It doesn't like go into my note, but it's a box that I would have
Brought
checked
a
it.
box in the computer?
Yes.
Okay. October 26th, buspirone, 5 milligrams, 30 count, same day by Tufts. You knew that?
Buspirone.
Yeah.
I was not sure that it was Dr. Tufts that had recommended the buspirone.
Okay, so if I suggest to you that the prescriptions that we have in evidence on the chart indicates that on October 26th, Dr. Tufts prescribed a 30 count of buspirone, would that either refresh your memory or would you accept that as being a medical history?
I would accept that.
And what is buspirone?
It is a medication used to treat anxiety.
Okay, and lorazepam, what is that?
Benzodiazepine.
And hydroxyzine, what is that?
It is an antihistamine medication.
And lorazepam, again, prescribed on October 21st as well as 26th by Tufts. That's the same thing you just told us what lorazepam is, right?
Yes.
Sertraline, of course, is Prozac. Is that right?
Zoloft.
Zoloft, Prozac. They're both SSRIs, right?
Yes.
So from October 21st up through November 9th, she was prescribed all of this group of drugs until she saw a Kavon Izadapana, Izadpanah. Do you know who that person is?
They work in the emergency department at South Shore Health.
All right. And that would have been on November 16th when she went into the emergency department, right?
Yes.
Prescribed trazodone, 50 milligrams, right?
Yes.
And then she started to consult with your clinic around the 25th of November. That would be around Thanksgiving or so, correct? November 25?
I believe her first visit with Julia was November 21st.
Okay.
So
What I'm saying is that it was around that time in November that she started to consult with your clinic, correct?
Correct.
You know that she was referred to your clinic by her mother-in-law, Pat's mother, who was a labor and delivery nurse.
Yes, I am aware.
Referred her to Julie Paul, who kind of stepped in for a very short period of time to try to help out, right?
Yes.
And then Julie left, went to New Hampshire to continue her work, and you picked up on November 30th of 22. Is that right?
November 29th.
On November 30th of 22, you wrote a script for quietapine, 30 count. Is that right?
Yes.
And what is quietapine?
Seroquel.
You also, a week later, wrote a script for diazepam, 5 milligrams. Is that correct?
Correct.
And then the next day, you wrote a script for, December 6th, you wrote a script for diazepam, 5 milligrams, right?
Correct.
December 7th, you wrote a script for diazepam, 5 milligrams, right?
Correct.
December 7th, again, you wrote a script for quietapine, 30 count, right?
I would need to check my...
You can look at anything you want. If
Okay.
you have your records, feel free, please.
Okay. You said
Yeah, it would
December.
be December 7th. And I'm looking at quietapine, 30 count, 100 milligrams.
I don't believe it was a 30 count of 100 milligrams.
Do you remember writing quietapine script for 100 milligrams?
I do. I believe the quantity was 22.
22. Okay. So on December 7th of 22, you wrote a script for quietapine, and forgive me, I'm sorry, what is that again?
Seroquel.
Seroquel, for 100 milligrams, right?
Yes.
And why did you write the script on November 30th for quietapine, 25 milligrams, and then about a week later increase it to 100 milligrams?
On November 30th, I had anticipated utilizing it over a 4-week course of treatment for sleep and anxiety. But her clinical symptoms, presentations changed, and we opted to use it for mood stabilization.
And who's we?
Me.
Okay. And were you working with anybody else, any psychiatrists or anybody?
No.
So when a person comes to your clinic as a woman who has recently had a baby or is within that postpartum range of time and presents with the symptomology that she presented, is that something that would give you cause for concern? Suicidal ideation?
I in no way want to minimize what Lindsay experienced, but it's common for us to treat.
It's common to treat women in that
Yes.
fashion that are
That are
postpartum?
Postpartum who may have suicide.
Keeps cutting off the witness before she gives an answer. May she complete her answer?
Sure. As I've said before, let's only talk one at a time. You finish your answer, and then we'll go to the question.
Go ahead.
Her symptoms were serious, and it's not uncommon for me to treat women with serious symptoms in the postpartum period.
Okay. 2 days later, you prescribed 8 count, 5 milligrams of diazepam. Is that right?
2 days from December 7th?
Yeah, it was December 9th.
December 9th. Yes.
And 4 days later, you prescribed more diazepam. Is that correct? December 13th?
Correct. That would have been 2 milligrams?
Yes. And then jump ahead to December 19th, you prescribed 14 count, 2 milligrams of diazepam. Is that correct?
Correct.
And then December 19th, you prescribed 300 milligrams of quietapine, 30 count, right?
Correct.
And that was on December 19th. 3 days later, on December 21st, you prescribed additional quietapine, 100 milligrams, 14 count, right?
Correct.
And then 1 day later, you prescribed more quietapine, 25 milligrams of 14 count, right?
Correct.
as far as your prescriptions continued on, if we can jump ahead, you continue to treat her, and on January 13th, you prescribed 2 milligrams of diazepam, 7 count, right? That would be on January 13th?
I did not prescribe that on January 13th.
All right, if I suggest to you that Rebecca Gelada has a script for January 13th of diazepam, that doesn't refresh your memory?
Would it have been a script that I had sent previously that hadn't been filled at the original date?
Well, I believe the records would indicate that. We'll make a note of it. January 13th, diazepam. How about January 16th? Do you recall prescribing diazepam to her, 2 milligrams, 3 count?
No.
Diazepam on the 19th of January, 2 milligrams, 14 count.
No.
No? So you're not able to prescribe medications, somebody else can't use your name, right?
Right.
And you have the DEA license to prescribe medications, correct?
Correct.
Now, one of the things that you went through was a lot of, obviously, it's a little confusing with the names of the various drugs. And the district attorney said to you blithely, she said, well, she's a nurse, so she knows what those drug names mean. Do you recall that question?
I do.
Yeah. And you just said, yeah, right?
Mm-hmm.
So you're assuming that a woman who gets her RN at the age of 24 in a 1-year program and then works for 7 years as a labor and delivery nurse is familiar with these names and what they are, what drugs they are?
She seemed to be familiar with them. Yes, she understood.
Right. Did you know that she was Googling 60, 70, 100 times a night what benzodiazepines are, what Seroquel is, what all of these medications are?
I did not know that.
Did you ever ask her where she acquired what appeared to be, apparently to you, her ability to know what these medications are?
I'm sorry, I don't understand the question.
Well, you wouldn't know the medications that a labor and delivery nurse uses when they're helping a woman who's giving birth, would you?
Not necessarily.
Okay. In any event, one of the things that you left us with is the fact that you were very, I think the word was invested in Lindsay Clancy and were concerned about her treatment, right?
Correct.
You knew that she had gone to the Rhode Island program for Women and Infants Center, Behavioral Health Day Program in Providence, Rhode Island. You knew that, right?
I did.
And you basically gave her the referral. You didn't make the referral. I think it was Latasha Dukes that might have done that.
Correct.
So you were aware of the fact that a recommendation was made to Lindsay that she reach out to someone else for help, right?
Lindsay made me aware of that, yes.
And she needed help, didn't she?
Yes.
And she went to Women's and Infants Hospital on December 20th, right?
She did.
And was she treated at Women and Infants?
I don't believe so.
Why not?
I wouldn't want to speculate or assume, but it seemed to be her intake appointment.
Her what?
Her intake appointment.
Okay. So without assuming or speculating, you referred her to this provider, right?
Yes.
So you have this woman who you know has been seeing Dr. Tufts, a psychiatrist, right?
Right.
You knew that. You didn't get access to Tufts records. You didn't know what Tufts was doing, but you knew that for a period of time before she saw you, she was dealing with a psychiatrist, right?
Yes.
You knew that she was a woman who had just given birth like 5 months ago, right?
Yes.
You knew that she was obviously in trouble. She was sick, right?
Yes.
You told us that she was suffering from, and your words were, a mental health illness that was very real. And you told her that this will get better. And that was in December of 2022.
Yes.
So when you referred her needing help to this Women's and Infants program in Rhode Island, and she went because that's what she was told to do, what happened at Women and Infants program?
I can't speak to what happened at Women and Infants
Why not?
because I was not a part of that assessment.
What does that mean?
I did not see the assessment and I did not speak with Dr. Diaz.
Why?
Lindsay had informed me that she was going to be at the program for 2 weeks.
She was hoping to be at the program for 2 weeks, right?
She told me she was going to be at the program for 2 weeks.
But she was turned away after about 8 hours of sitting there in an assessment and sitting in a group session. And she was turned away because of their concern that she was suffering from, well, let me ask you, what was their diagnosis?
I'm not sure.
Did you ever find out?
I have not.
Does it matter to you as a treating person that I think your words were is invested in Lindsay Clancy's care at that time? Did it matter to you why she didn't get accepted into the program?
It did.
Why was it?
I do not know their diagnosis.
Did you know that she had been diagnosed? You have different diagnoses, right? Like general anxiety disorder or general anxiety, GAD. And then you have, is it a differential? Is that what it's called?
Mm-hmm.
What does that
Yes. It means a differential in medicine could be patient comes in with a cough. What are your differentials? Differential might be bronchitis, pneumonia, strep throat. So it's different things, different diagnoses you consider.
Did you know that, in fact, they wouldn't accept her into the postpartum program because of their concern that she had been over-medicated by drugs and they wanted to find out?
I can't speak to that.
Did you know that she was diagnosed as diagnosis depression due to adverse drug effects?
I cannot speak to that.
Do you know, invested as you were, that on December, strike that, on December 20th, the very same day that she had finished being evaluated, woman you were invested in, had been evaluated by Dr. Diaz that you recommended or you mentioned, that in fact, looking at the exhibit, that they recommended tapering Seroquel, starting 200 milligrams tonight, follow up with outpatient provider of note. We attempted to reach current outpatient provider Rebecca Gelada, but did not receive a call back.
I never received a call from Women and Infants.
So this medical record from Women and Infants saying that they called Rebecca Gelada and never got a call back, your memory is that they never called you?
They never called me. I absolutely would have called them back.
Okay. Well, regardless, you never talked to anybody from Women and Infants, did you? Whether they called you or whether you reached out to them being invested?
I did not. I know our program re-referred her a few days later.
I'm going to offer this now, Your Honor. I think just
It's already in evidence.
yeah, I know. Let's just,
We've marked,
it's just certain dates.
yeah, well, I'll allow, we'll keep it as an exhibit for identification. You can double check, make sure the pages that have been referred here are contained within, is it exhibit 220?
Yep.
And if not, then we can admit the second.
Okay, thank you. One of the things that is a takeaway from your treatment of Lindsay is that she was, I think your words were that she was scared and thought that starting these drugs, the drugs, it was scary, were her words, right?
Yes.
And at no time did it occur to you that Lindsay was doctor shopping or trying to get drugs. She was trying to basically get off drugs, right?
Correct.
One of the things that you had mentioned is that the Good Moms Have Scary Thoughts book is something that you guys would give out to women when they would come into your program.
Yes.
And hopefully it would be a good source for them to read things and maybe get some comfort from it, right?
Yes.
This is not, in your opinion, something that is indicative of like being a smoking gun.
No.
Police officer would seize it in the search warrant.
No.
This is something you guys provide people to just help them out, right?
Yes. Yeah.
And just a couple of things. So on November 17th, she had an office visit with you. Is that correct?
Not on November 17th.
Okay. And you are South Medical Center, right?
Yes, that may have been her PCP.
Okay. Is that her PCP? Is that person that would be under the umbrella of the South Shore Medical Center?
Yes.
Would that be Kimberly Tocchio?
Yes.
Okay. So you must have read Kimberly Tocchio's records, I would imagine, right?
Yes.
And you know that she was seen, record indicates that she was seen by a psychiatrist, and this would be November 17th note, started Zoloft 25, which was then increased to 50 milligrams, right?
Yes.
And she took the Zoloft 50 milligrams for one night and was unable to sleep and was discontinued because of the effect that it had on her, right?
Yes.
Now, one of the things that you had mentioned is that it's important to determine, and you did have thoughts of possibility that she was bipolar. Is that correct?
Correct.
And one of the things that is contraindicated to someone who does suffer from bipolar, whether it's 1 or bipolar 2, is that you do not place them on a selective serotonin reuptake inhibitor drug, such as Prozac or Zoloft, right?
Correct.
Because it can have an effect on them, isn't that right?
Correct.
And what's the effect it can have on them?
It can cause what we consider rapid cycling, meaning you can swing from mania symptoms to depression symptoms relatively rapidly.
On November 21st, did she have a meeting with you all? If you recall, looking at the records, did she meet with Julie Paul?
Yeah.
Know?
Yes.
Okay. And she gave Julie a history of what she had been going through. Is that correct?
Correct.
And in that history and in her talks with Julie, she had disclosed the fact that one of the things that she did in November was took a marijuana gummy, one gummy, to try to sleep, right?
Correct.
And again, her medical tests, blood tests, urine tests, everything showed that she had no alcohol, no THC, nothing on board, but she still disclosed the fact that to try to get some sleep, she took one gummy in November, right?
Yes.
So again, she's reporting, trying to be honest with you people as a provider, correct?
Yes.
And the scales that council asked you about, you were talking about the depression scale, you were talking about the Edinburgh scale, and I think we all know that the Edinburgh scale is geared for an evaluation of a person, of a woman who is in that postpartum period, and you evaluate whether or not they are, as a result of being postpartum, severely depressed, right?
Yes.
And you indicated that at some point her Edinburgh scale was initially, what was it, 15, 17, if you know?
Initially at my visit, my first initial with her.
Yeah, what was her Edinburgh scale the first time you saw her?
17.
Okay. And that would be moderate?
Moderate.
Okay. And then she had another Edinburgh scale after that, correct?
Correct.
And when was that, if you know?
December 6th.
And what is EPDS? What does that mean?
Edinburgh Postpartum Depression Scale.
All right. So would you look at November 21st, please, which would be, so November 21st, she was administered a Edinburgh test, right?
On the 21st. That would have been at Julie's appointment. I don't have that in front of me.
If I told you that, well, on November 21st, it's a short period of time after November 17th, did they, whether it's Julie or somebody else, administer Edinburgh test to her?
Yes.
And what was the result?
23.
That's severely depressed, isn't it?
Yes.
So in like 6 days, she decompensated from Edinburgh scale 17 to Edinburgh scale 23, right?
So she was 23 on November 21st.
Right.
And 17 on November 29th.
Okay. So when you see a patient that's come to you and has an Edinburgh scale of 23 and an Edinburgh scale a couple of days later, that would be, what was it?
17.
And what was it when you first saw it? You referenced it before, 17?
17.
Yeah, that's still pretty high, isn't it?
It's high, yes.
Would that give you pause in conjunction with the symptomology that she's referring to and self-reporting what she's feeling? I mean, the fact that she has a 23 on the Edinburgh scale, which is very high, and then followed up a couple of days later by a 17, taken in conjunction with what she was saying her symptoms were. That's of a concern, isn't it?
Yes.
So on November 20th, which would be the day before that Edinburgh scale of 23, and the jury will have access to all these records, she was reporting struggling with postpartum anxiety, right?
I can't speak to
Okay,
that.
that's fair enough. We'll go to when you treated her.
Yes.
Did you have a chance to review Julie's notes at all?
I did.
Okay.
Yeah.
And when was the first time that you actually met with Lindsay?
November 29th.
Okay. Which would have been after Thanksgiving, obviously, right?
Yes.
And you would have reviewed the records up to that point, right?
Yes.
So one of the things that you would have reviewed was what she had indicated or reported to Nicole Harden Francis. Do you know her?
Yes.
And who is Nicole Harden Francis?
She's the nurse at our program.
All right. And this would be on November 28th that she was speaking with Nicole, the nurse. You read the report before you met with Lindsay on the 29th, right?
Right.
So you knew that she had been reporting panic symptoms, that she was disoriented, that she was forgetful, that she was not connected to her body, is what she told her, right?
I would have to review that just to be accurate. That's correct.
Okay. And would you agree with me that symptomology of mania, especially when incurred or encountered by a woman within the postpartum period, that's one of the symptoms, is being disoriented, right?
Not necessarily.
How about maybe a little bit?
Could be confused if you're manic.
Yeah. How about forgetful? That's an issue, isn't it?
Not necessarily a symptom of mania.
Okay. How about not connected to her body? What does that mean?
I'm not sure what that means.
So if you have a patient who's coming to see you, who's indicated the day before that she has the panic symptoms, disoriented, forgetful, not connected to her body, wouldn't you ask her what she meant by that?
Yes.
Okay. So when you saw her on November 29th, you diagnosed that she had postpartum anxiety, right?
Mm-hmm.
Adjustment insomnia, right?
Correct.
And when you met with her, you noted that over the last 2 weeks, you asked her about how she had been feeling, and she said she was feeling nervous, anxious, and on edge. She said nearly every day, right? That's November 29th. That would be under screenings.
Yes, she was.
I would give you a page number, but they don't give us page numbers. She told you, and you can pull it up if you have it there, that she was not able to stop or control worrying, and that had been for several days at least, right?
Correct.
And she was worrying and stressing about things, worrying about different things every day, right?
Nearly every day, yes.
Couldn't relax nearly every day. This is a questionnaire form that you have, right?
Yes.
Being so restless nearly every day, correct?
Correct.
Asked if she was annoyed or irritable, and she said not at all. Sure, like she didn't believe that she was a person that would be irritable or angry with people, right?
Yes.
And then feeling afraid, as if something awful might happen, and she got that GAD 7 score of 14. Is that correct?
Correct.
So what does a GAD score of 14 tell you on November 29th?
Moderate anxiety.
And then you ask about in the last 7 days, trying to get a history. She denied, definitely not so much now, that she was able to laugh or see the funny side of things, right?
Right.
And that she was asked, is she looking forward with enjoyment to things? And she responded, hardly at all, right?
Yes.
Blaming herself when things go wrong, she says, yeah, some of the time. Yep.
Yes.
Anxious and worried for no good reason. Yes, correct?
Yes.
Scared and panicky for no good reason. Yes, correct?
Yes.
Then they asked if she felt sad or miserable, if she was a miserable person, and she said, no, not at all, right?
Right.
Did she indicate that on that date, you gave her the EPDS Edinburgh test, and she had an Edinburgh score, as we said, of 17, right?
Yes.
All right. And then the medications that you prescribed to her, we've already got an evidence. The jury will be able to look at the actual scripts in the exhibit without going through every single day. The next time you saw her was November 30th. Is that right?
I messaged with her on November 30th, yes.
Okay. And you indicated that if you're not sleeping well with Valium, no need to continue it. I'll prescribe a short taper. And you went on about tapering and 5 milligrams of Valium to 2.5 milligrams and no benzos. And
That was not on November 30th.
okay. Does it say on the record, are you looking where it says patient message in the perinatal behavioral health program of South Shore Health, November 30, 2022?
Yes, I'm looking at the messages.
Okay. So is it a different date that you sent that message? It says November 30th on it, right? I just don't know internally if you guys have different.
Oh, I understand. Oh, at the top it says November 30th.
Yeah.
More specific, it'll say the dates, but the header will say November 30th. So I understand.
Okay. And basically you indicated that you were going to send along information about bipolar 1 or bipolar 2, which actually would be what's known as a bipolar spectrum disorder. Is that correct?
Yes, that was on December 7th.
Okay, but it's underneath November 30th, so forgive me for looking at it that way.
Yeah, I don't know why. I
That's all right,
printed
no problem. So one of the things with the mania that you refer to and that you talk about is excessive activity. Is that it? Excessive cleaning sometimes, right?
Sometimes.
Excessive exercise.
Sometimes.
Did you know that after she had Callan, that within a matter of a couple of weeks, that she ran a 5K?
No, I did not know that.
And that nobody wanted her to, including Pat, but she just had to get out there and run and did.
Objection.
Overall.
You know that?
I did not.
Is that something that would be important to know? I mean, as far as whether or not a person is in that manic stage where it's post-delivery, and that's a significant artifact, if you will, of exercising, right?
It would have been something I would have considered.
Okay. And as I said, you were pretty much the only one that actually considered bipolar spectrum disorder of all the doctors that she had seen. You know that, right? Are you aware of that? All right, never mind. That's right. She's going to object. That's okay.
Okay.
So the symptoms that you noted were mania. It says mania characterized by exaggerated excitement, hyperactivity, and racing scattered thoughts, right?
Yeah.
So what is, go ahead.
Was that from my note?
I'm looking at the same thing that we've been looking at, which is.
Oh, the information I sent her on bipolar.
Yeah, it says,
yes.
Hi, Lindsay, and then your note, right?
Mm-hmm.
Your Honor, if I may suggest maybe showing the witness what he's referring to.
She has it in front of her.
I think I understand what he's referencing, but
So-
thank you.
If the witness has a problem in regards to that and you need to look at some, just let me know. Okay.
Okay.
All right.
Thank you.
Thank you. If you move ahead to, I think the message portal or whatever it's called, on November 30th, it's captioned "Stopping Remeron." And
Yes.
it's, okay, you're with me. And it says, no, this would go to the fact that she was still not sleeping. It was a huge problem for her, right?
Yes.
And she told you in her message thing, no, the weird thing is I don't feel tired at all.
Correct.
And that's one of the things that you had told us earlier is a symptom, correct?
Correct.
A person that is not getting sleep but doesn't feel tired.
Correct.
What is a symptom of?
It's a symptom of mania that we look for.
Okay. And when we looked for that mania, did you notice that? And did you factor that into your diagnoses?
Yes.
Okay. How many times, if you recall, did Pat come with his wife to meet with you? Was it 3?
He came to a visit once. I believe I spoke with him and Lindsay on the phone twice.
Would you agree with me that, as counsel asked, did he get permission to be there? And you indicated no, that you would welcome the third-party contact, right?
Correct.
And did it appear to you that he was very, very invested in her care and was very scared and worried?
Yes.
And he was complaining about the fact that he believed, or they believed, that she was being over-medicated, right?
I believe he was concerned about her symptoms. He felt that they started once she started being medicated initially.
Right, because she indicated that when she first started taking the SSRI back in October, I believe, that she ended up having it increased and then had a period of almost 2 days where there was no sleep whatsoever. That was one of the instances, right?
Yes.
She also, counsel had asked you, and you did not recall her saying horrible, intrusive thoughts. So if you would just look at November 30th patient message. It says, "Hi, Rebecca." And then it begins, "I don't expect you to answer this until Monday."
I see that.
Okay. And then she says how she basically only slept for about 4 hours at the beginning of the night at 9:30 and then dozed off for 45 minutes and said, "Today, all day, I had horrible, intrusive thoughts and deeply depressed," right?
Yes.
So when was the next time that you saw her after she sent that message on November 30th?
I would have seen her on December 6th. She had sent this message, I believe, on December 3rd, and I saw her on the 6th.
So on December 3rd, and again, it would be the way that they print this thing out. It has a date of November 30th, but then underneath it, it would be a different date of December 3rd. Is that right?
Yes.
Okay. And when you, as an invested nurse practitioner, receive a message from a woman who is postpartum, who has been through what she's been through and the symptomology that she explained and the doctors that she's seen, not too very good results, you'd be concerned when you see a person saying, "I have horrible intrusive thoughts," right?
Yes.
All right. So as a result of seeing on December 3rd that Lindsay Clancy, with her history, had been telling you that she had horrible intrusive thoughts, what did you do? Did you call her?
She had told me that she took the Ativan and now the thoughts were gone and she had felt good.
So,
but I did speak to her about it.
Yeah, but she told you
at her
that
next
in
appointment.
she told you that in her message.
Right.
That she had today, all day, I had horrible intrusive thoughts. Deeply depressed. I finally took 0.5 of Ativan at 6 p.m. And the thoughts are gone, is what she told you, right?
Yes.
Did you ever bother to ask? I don't know. I mean, would you ask the patient what the horrible intrusive thoughts were?
I would have, yes.
Did you?
Yes.
What did she say?
She described them as thoughts of not wanting to be here.
How about, did she ever describe to you that she was hearing voices?
No.
How many people have you treated for postpartum psychosis?
5.
And of those 5 people, did they hear voices?
Not all of them.
How about some of them?
Some of them.
And that's a real thing, isn't it?
Yes.
And visual hallucinations likewise?
Not all.
So with the voices, that would be an auditory hallucination.
Yes.
Visual hallucination, not all, but some.
Yes.
And that's a real thing.
Yes.
So when she had horrible intrusive thoughts, did she say where these happened? Like, was she in the yard? Was she in her car? Did you ask her where and what? Or was it just that she just didn't want to be here anymore?
It was more that she didn't want to be here anymore.
Okay, did you ask her what that meant?
I did ask her if she had any plans or intent for suicide, which changed at different times during our treatment.
So on December 2nd, you have received you sent a note to Lindsay and said it, meaning what she was telling you in a prior communication, it sounds more like depression than side effects. That would be of drugs, right?
Correct.
It is not uncommon for me to hear, and then you quote, I have never felt anything like this before, end quote, or quote, I just don't feel like myself. All of this sounds like postpartum depression. Is that correct?
Correct.
All right. So she was expressing all of the symptomology of depression, what you believe would have been side effects, and you indicated that at this point, while you're working through it, this sounds like postpartum depression, right?
Correct.
And what would the symptomology of, what does postpartum depression mean, and what is its effect on a patient?
Postpartum depression is like depression at any time during a patient's life. However, there are some unique considerations. It's typically occurs in the first 3 months after a person has a baby, but it can happen at any point in the first year. The considerations that are a little bit different than regular major depressive disorder are that there are significant hormone fluctuations that a person undergoes when they deliver a baby. Sometimes they breastfeed and they wean from breastfeeding, and that can set off additional hormone shifts. And it tends to be a very anxious presentation. And obsessive thoughts can occur with greater regularity in postpartum depression than they would with major depression outside of the postpartum period.
So as a result of this information, you prescribed medication to her?
After I sent her the information on the postpartum, would this still be December 2nd?
Looking at the form that you have, it would be, yes, but I don't know if it's another date that there's a message underneath it. So let's look at the record where it says that on December 7th.
7th,
Yes.
Okay.
And that's where you talked about bipolar spectrum disorder, right?
Yes.
And that's where you talked about how people would have these feelings of goal-directed activity, overly talkative, racing thoughts, need to sleep, things of that nature, right?
Yes.
What was the end result of that? Did you prescribe medication for her?
I did.
And what was it?
Seroquel.
One of the things that you had mentioned is that you provided a mood chart, I think. Is that what you said? A mood chart? Is this it? Is that an indication just so the jurors know that it's in the records? It's a horrible.
That looks accurate, yes.
Yeah. Yeah, there it is, right there. See on the very top, it says mood chart. To the left?
Yes.
All right, and on the top, it says daily mood chart. And then you also provided another chart on that date. What is that? That's another variation of it?
It's the weekly mood chart.
Okay. So did you tell her to fill this out?
I suggested that she fill it out so we could keep track of her symptoms.
Okay. Do you remember if she filled it out when she spoke to you?
She did not speak to me about filling it out. After that, she did say she printed it out.
Okay. Did you ever ask to see it?
I don't recall.
Okay. On December 1st, you met with her, is that right? Oh, no, wait a minute, Christine Zappi. Who's Christina Zappi?
I believe she's also someone that works at South Shore Medical Center.
All right, do you know that she saw Christine Zappi on December 1st? Christina, I'm sorry, it says Christina.
I'm not sure if she saw her for a visit that day.
Okay. Have you seen in the pool of records that you have that she did see this individual and noted that she had been dealing with the problems, the insomnia symptomology, for over a month and a half, and medications keep changing, and it doesn't seem like much is helping? Did you ever see that?
That does sound familiar.
Okay, so she was somewhat in, this is almost hand in glove with saying, I'm not being hurt, right? Same
Yes.
idea. Did you see her on December 2nd, the next day?
I spoke to her on December 2nd.
Okay. And again, the district attorney kept asking you about, she had the opportunity to come in and see you if she wanted to, and things of that nature, right?
Yes.
And would you agree with me that it's sometimes better to have a face-to-face actual meeting with a patient rather than just on the computer?
Yes.
Did you ever, if you recall, with all of the symptomology and deterioration going by week after week, say to her, I really think that we should get together in person?
Yes. So we met in person on the 6th, and our plan had been to meet in person on the 13th.
Okay, so that would be December 6th, correct?
Mm-hmm. Yes.
Now, December 2nd, you had a conversation with her on the phone. Is that right?
I believe it was just my chart messages.
Okay. So you see on where it says, again, it's got the big black letters, December 2nd, 22, and then underneath it, it says behavioral health history. Can you find that on your records? If you don't, that's fine. That would be the time that she indicated that she had been to the ER for anxiety symptoms as well as insomnia and heart palpitations. You remember that?
I don't see that.
Okay, well, then let's get it. Do you have access to other staff notes and records, right?
I do. I only brought my own.
Okay,
with me.
that
Yeah.
answers that. So if I approach you,
Yes.
Can I see what you're showing her first? Sorry.
sure. Yeah. Latasha Dukes. Who's Latasha Dukes?
Letitia Dukes was a clinician at our program at the time.
All right. So am I looking at Letitia Dukes, MSW? What does that mean?
Master of Social Work.
All right. And does that indicate a date that Ms. Dukes saw Lindsay?
December 2nd.
All right. And on December 2nd, again, she was complaining of symptomology, she meaning Lindsay, having heart palpitations, right?
She's describing that she had heart palpitations and she went to the ER for anxiety symptoms.
Okay, so the answer is yes.
Yes.
Okay, so
Yes.
And that she then went to the ER, and per a patient's report, she has an addiction to Ativan, and that's why she can't sleep. And she also noted had weight loss, right?
Correct.
And panic attacks, right?
Correct.
So she's got a fear that she's on the benzodiazepines by script that she didn't want to be on, and she couldn't sleep, and she was losing weight, and all the other symptomology that we talked about, right?
Correct.
And that's in December.
Yes.
December 5, Nicole Hayden Francis had a chance to speak with Lindsay. And at that point, there was a recommendation that she might want to try INPT LOC. What does that mean?
Inpatient level of care.
Okay. And that would be Nicole Hayden Francis, who's a nurse, was telling her that on December 5.
Yes.
Now, and again, I know you don't have the records from Letitia Dukes, so if I may approach.
You may.
on December 5, and you correct me if I'm reading these wrong, this would be Letitia Dukes, December 5, right?
Correct.
And on that occasion, Letitia Dukes notes that she called Aspire Crisis Support, she meaning Lindsay, right?
Yes.
What is Aspire Crisis Support?
Aspire is the community mental health program that operates the local 24-hour emergency services program for psychiatric emergency services.
Okay. So when I say you collectively, I mean psychiatrists, nurse practitioners, RNs in the psychiatric world, tell patients that are in crisis that if you feel that you're going to have suicidal ideation or anything, you should call these numbers, is what you people will give them, right?
Yes.
All right. She called Aspire Crisis Support, not once, but twice, right? If you know.
I'm aware of the one time she called.
Okay. But she was not given any help at all by Aspire, whoever they are, right?
I'm not aware of that.
Well, it says right in the records from Letitia that she met with an Aspire clinician virtually and was told that she did not meet the criteria for inpatient treatment due to not having an SI plan. What does that mean? They just told her you're not laying on the ground with your throat cut, so we're not going to be able to help you?
Can't speak to what they told her.
So Aspire then recommended that she start or go to a day program. Is that correct?
That's correct.
And the clinician said that he, from Aspire, would be sending the patient resources, right?
Correct.
But they never did they? If you know.
I don't know.
Further, Letitia notes that they reviewed the sleep hygiene with the patient. Clinician provided patient suggestions for meditation, grounding, self-soothing techniques. What's a self-soothing technique? You know.
It might just be simple strategies to soothe yourself using any of your 5 senses.
And she notes, and again, this is on December 5th, that Pat, patient's husband, joined the visit, reporting that her anxiety had become significantly worse since starting the psychiatric medications. Did that say that?
That is what that says.
Okay. And in fact, when you spoke to Pat, he had told you that, in his quotation, his words would be, it was 10,000 times worse since she started this medication, right? If you know.
I don't recall him using that phrase.
But he was upset about the medication, wasn't he?
I would say he was concerned.
Do you recall that he said that you're turning her into a zombie?
I do not recall that he said that.
So would you say to the jury that he was concerned or he was pissed off about the medication and what it was doing to his wife?
Objection, Austin answered.
No, overall.
I would say he was concerned.
Concerned? Okay. Did anybody address his concerns?
That day.
Any day?
I would say that day I collaborated with them to take her off certain medications.
Okay. December 6th, you had a meeting with her, is that correct?
Correct.
Again, she's diagnosed postpartum anxiety, right?
Correct.
Her EPDS score, as a result of being administered, the Edinburgh test was at that time a 21, right? That would be underneath office visit and perinatal behavioral health, above assessment and recommendations.
Correct.
And 21, how would you grade that?
Severe.
Severe what?
Severe signs of postpartum depression.
Do you know that she had lost over 15 pounds by that point?
I was aware she had lost some weight. I was not aware that it was 15 pounds.
Okay. So then there was another patient message on December 7th where she again was expressing concern about the drugs, and you indicated Either way, I continue to recommend the Valium taper, right?
Correct.
There was a period of time that she indicated that she wanted to get off the medication and get off the drugs, and you indicated, as you told us, that you were on vacation that week, right?
Yes.
You basically told her to tough it out and just hit me up when I come back from vacation, right?
No.
Did you tell her to call you when you came back from vacation?
No, I asked that she try to hold off and wait for me to come back from vacation for the taper. She had wanted to taper it sooner.
All right. Do you have somebody that covers for you if you're on vacation?
Yes.
Does somebody cover?
She said that she was going to follow up with her other psychiatrist for the taper, but she did reach out to our program while I was on vacation.
Sorry, I couldn't understand you.
I'm sorry. I know that she said that she had an appointment with her psychiatrist who would do work on the taper with her. And I do know that she was in contact with other providers at our program, including Letitia Dukes, while I was on vacation.
And Letitia Dukes is a social worker, is that right?
Yes.
Okay. December 9th, there was another telephone encounter, it's called, right?
Yes.
And yet again, her husband, Pat, was involved with this call, right?
Yes.
So does this put Patrick up to around 4 times, maybe 5 times that he had been involved either in person with your business or on the telephone or on the telemetry or whatever it is, computer?
I spoke with him on the phone twice. He was in one of our visits on December 6th, and it appears he was in the visit with Letitia as well.
So this would be a Rebecca Gelada telephone
Yes.
encounter on December 9th, right?
Correct.
And on that occasion, Lindsay, and it says, and her husband called this writer, that'd be you, right?
Correct.
Regarding the plan to taper, correct?
Correct.
And they both agreed that Lindsay's symptoms remain too acute. What does that mean? What's acute mean?
Severe.
Did they say that she's sleeping but waking up with, let me back up. Was he telling you all of this while she sat there? She wasn't saying much in that conversation, was she?
I don't recall who was saying more than the other person.
Do you recall that she indicated that she wanted her husband to be involved to speak for her because she was really decompensating, right? She wasn't self-reporting and self-advocating too well for herself at that point, was she?
I just know she did have her husband on the call, and he did speak on the call.
They indicated that she was waking up with panic symptoms, right?
Correct.
What panic symptoms? What does that mean?
Panic symptoms can be this sudden rush of intense.
That's not what can be. What did she tell you, or what did her husband tell you? Her
panic symptoms. Panic symptoms.
What were they?
Panic symptoms are racing heart, intense fear. Those are panic symptoms. Sudden rushes of intense anxiety that seem to come out of nowhere.
Okay. Is that something that you learn in school, or is that in a book? Is it in the DSM, or what? So we all have our own opinion as to what panic symptoms might be, but from a medical standpoint.
Those are what panic symptoms are.
Would you agree that Patrick, in this conversation, also indicated that she was having intrusive thoughts yet again? Right?
Correct.
What were the intrusive thoughts that she was having when she wakes up with panic symptoms?
I don't recall the specific intrusive thoughts. I recall asking about safety and that she did identify having thoughts of suicide.
Well, Patrick told you that she has thoughts of suicide, right?
Lindsay as well.
Okay, so I'm asking you what you, as an invested healthcare provider, told this woman to advise her what your investigation revealed. If you have a patient tell you I'm having intrusive thoughts. What were they?
I recall that they were intrusive suicidal thoughts.
And is this a frequent theme that you noted?
I don't know if it was a frequent theme that I noted, but I know that it was documented several times throughout her course of treatment with providers in my program.
So at this point, with all the providers of your program and her indications, as well as her husband's, about the number of times that she had suicidal ideation, did you prescribe more drugs for her?
At this occasion, I prescribed Valium.
You bumped her up to Seroquel to 400 milligrams, didn't you?
Yes.
Did that help? How'd that work out?
At 200 milligrams, she was able to sleep. So I felt that the manic symptoms in her mixed presentation were alleviated at 200.
So on December 12th, she sent you one of those messages. Thank you, Rebecca. December 12th. She says, for the last 3 nights, I've taken 2.5 milligrams of Valium and 200 of Seroquel. I have to say, I do like the way it makes me sleep deeply and soundly for about 7 or 8 hours. I don't like the way I feel in the morning. That you read that to the jury for the DA, right?
Yes.
But then the rest of the sentence is incredibly depressed and unmotivated to do anything at all. Do you remember her saying that?
Yes.
Now, you'd agree with me that that's one of the observations that you make or symptomology of a person that's suffering significantly from postpartum anxiety, depression. She's incredibly depressed and unmotivated to do anything, right? What
Correct.
does that mean? What does she mean by that?
I'm not sure I understand the question.
When she says that she's unmotivated and is incredibly depressed, was she able to go shopping? Could she get in the car and drive? Did you know that she stopped driving?
I was not aware of that.
On December 12th, she saw Letitia Dukes. Patients reporting thoughts of SI, suicidal ideation, but no plan. She contacted Crisis over the weekend and will be starting a PHP in Norwell. What does that mean?
Partial hospitalization program?
Okay, and that's because, yet again, she's reporting the suicidal ideation, correct?
Correct.
And there's a difference between suicidal ideation and having thoughts of suicide, right? Under the DSM, is there?
There's a suicidal ideation can be a spectrum.
Okay. On December 13th, telemedicine in the perinatal behavioral unit. Again, there was a concern about suicidal ideation, and her look underneath Edinburgh postnatal depression scale, if you have it, was now 20. It's still severe, right?
Correct.
So what did you do on that date, if you know, December 13th?
I recommended that she continue Seroquel 200 milligrams and Valium 2 milligrams.
December 19th, telemedicine with Letitia Dukes. And this is when she indicated that she was going to contact Women and Infants, and Letitia helped her out to do that. So she went to Women and Infants on the 20th, right?
Correct.
Okay. So as time went on, and she had gone to Women and Infants and was unable to be treated on December 20th and went home, or picked up by her husband. What was her course of treatment after that? You didn't talk to anybody at Women and Infants, right?
At that time, I did not talk to anybody at Women and Infants, but I do know that we re-referred her in a few days.
I know you already told us you re-referred her. My question is real simple, and I don't mean to be bully. I just want to ask you.
Yes.
Did you talk to anyone at Women and Infants?
No.
So, as I read the record, which is an exhibit, Women and Infants, December 20th, differential diagnosis, concern about medications, reaches out to Rebecca Gelada, no return call from Gelada. You don't recall that. You don't know what happened to her after that, do you? Other than going to McLean.
I know that she went to McLean.
Right. Do you know when she went into McLean?
At the end of December, early January.
Okay. Did you review the McLean records? Because you have access to them, right?
I do not have access to them.
You don't?
I don't.
So if you're treating a person for all of the stuff that we've talked about, and it's now apparent that things have decompensated so bad that they have voluntarily admitted her to a locked ward in a mental institution, is it important to Rebecca Gelada to find out what the diagnosis and treatment was of their patient?
Yes.
Did you find out?
I did not.
And anytime you called in an ROI, anytime you needed a release of information, such as a HIPAA release, she would have signed it, right?
Objection.
Overrule.
Would have.
You have no reason,
Speculation.
well, not hardly.
I'm going to allow that. The jury can weigh that. You can explore that on a cross-examination. Redirect, I'm sorry.
From your treatment of Lindsay and her efforts to be a good patient and tell you all what her symptoms were and third-party contacts and everything, she, to your opinion, she would have signed a release for you to get access to pretty much anything you wanted, right?
I'm not sure if she signed a release for McLean to be able to speak with us.
Did anybody ask her? Did you ever ask her to sign a release?
I did not.
That's all I had, Your Honor.
All right, Attorney Buckingham?
Mr. Lotta, Lindsay Clancy was only a patient at the South Shore Perinatal Behavioral Health Clinic between November 20th and December 13th. Fair to say? Meaning November 20th is the first contact she had with Julie Paul, right?
Yes.
And December 13th is the last time that you met with her.
Yes.
And she came to that clinic not from a referral from somebody like Jennifer Tufts, correct?
Correct.
And so your information about her contact with that psychiatrist is limited to what she shared with you.
Correct.
And she never offered to you that maybe you should talk to her, did she?
Correct.
Now, you've also been asked about providing all the different medications. And if I may approach with Exhibit 1, please.
Yes, you may.
I'm going to show you the second page there. I know it's kind of small, but take your time to take a look at it. Do you ever see on there that you prescribed any medications to Lindsay Clancy in January of 2023?
None.
And in fact, January 12th of 2023 is Jennifer Tufts, correct?
Correct.
January 5th of 2023, Aaliyah Goodhart, correct?
Correct.
January 16th, Jennifer Tufts.
Correct.
Jennifer Tufts for diazepam. Jennifer Tufts for diazepam. So your last prescription filled is December 22nd, 2022.
Correct.
So when counsel asked you about this chart he was reading from,
Yes.
you would agree with me, this record from CVS is what you would generally see when you pull a patient's prescription lists.
Yes.
And as far as the going back through some of the medications, and you were read by counsel about on December 6th and 7th, prescribing the same medication, is it common that you would change prescriptions to adjust for dosage?
Yes.
And when you start some new medications, do you give somebody an automatic 30-day supply if you're not sure if that's going to be the course of medication?
Correct.
So sometimes you're prescribing things at kind of odd dosages, right? Or odd number of pills.
Yes.
So on December 6th for the diazepam, you actually prescribed 1 pill.
Yes.
And then December 7th, 2 pills.
Yes.
And then December 9th, a 5 milligram dose, 8 pills.
Yes.
And then on December 30th, I think it is, 2 milligram dose, 7 pills.
Yes.
And then the Seroquel as well. On November 30th, when you first prescribed that at that low 25 milligram dose for insomnia, she was given 30 pills.
Yes.
And then when you changed the plan as of December 7th, you had to give her a new prescription for a higher dose, didn't you?
Yes.
So that's the 100 milligrams at 22 pills.
Correct.
Now, when you adjust the dosages or adjust the number of pills, do you give specific instructions on how to take the medication going forward?
Yes.
Do you expect the patient to follow those instructions and disregard the previous prescriptions?
Yes.
Now, at several points, you've indicated and counsel asked you about referrals or recommendations that Ms. Clancy go to a partial hospitalization program, right? Do you recall that line of questioning?
I do.
And does South Shore Perinatal Behavioral Health have a partial hospitalization program?
Not at this time.
And so oftentimes you have to pair or recommend places outside in other communities, correct?
Correct.
And you've talked about women and infants, and that's one of the places that you've referred and that you did in fact refer this patient, correct?
Yes.
You don't have an affiliation with women and infants, do you?
No.
So any information that you receive would have to come from the patient or at the patient's request. Is that fair to say?
That's fair to say.
In regards to her visit to women and infants in December 20th, you had contact with Lindsay Clancy the next day, didn't you?
I did.
And that was through the MyChart messaging?
Yes.
And she explained to you what happened at Women and Infants?
Yes.
She gave you details about what they told her, that she wasn't going to benefit from the groups, and that when she told them about her medication history or medication issues, that they believed that she should come off Seroquel.
Yes.
So while you don't have the records of the diagnosis, you had a report from the patient about what they were recommending, didn't you?
Yes.
And as a result of that, you started a conversation with her about tapering Seroquel, didn't you?
Yes.
Council bounced around a little bit with the dates, but as far as some of the communications and contact with her, in December or November 30th into December 1st, were you talking to her about postpartum depression?
Let me double check, please.
Mhm.
I was.
So that's when you sent the information and the mood chart, right?
Yes.
So that's November 30th, December 1st. And now by the time you get to December 7th, after having pretty significant back and forth communication with her, now you're talking with her and giving her some information about bipolar, correct?
Correct.
So upon her presentation at the clinic and her initial focus of treatment, it was for postpartum depression and anxiety, was it not?
Yes.
And as you began to have more contact with her, as you began to trial different medication regimens, is that when your differential diagnosis started to emerge?
Yes.
And you responded to that appropriately with the medication you recommended, right?
Yes.
That's why the titrating of Seroquel became a conversation. Is that fair to say?
Yes.
And when you, after the Women and Infants program on December 20th, you didn't see Lindsay Clancy again in the clinic, did you? Either telehealth or in person?
No.
And the only contact you had with her was through the messages about the plan for tapering, correct?
Correct.
And while you were going to be away and not available to her, you still gave her a plan and a prescription to assist with tapering, didn't you?
I did.
Was your clinic or your colleagues still available for her if she needed it?
Yes.
Did she reach out?
I believe that either she or Patrick did reach out on December 30th.
And that was for a higher level of care recommendations, right?
Correct.
But as far as issues with the taper, did she reach out to you or your colleagues about issues with the taper?
No.
Now, council went through with you a call in which Patrick and Lindsay, or Lindsay indicated to you that she was having panic symptoms and intrusive thoughts. Do you recall that?
Yes.
In that call, did you contract for safety?
Yes.
What does that mean?
It means assessing immediate safety. For example, not to speak in hypothetical, but if somebody was saying, I have a plan to kill myself, I have a knife, I am calling 911, I am sectioning that person. If somebody's saying, I'm having thoughts of suicide, okay, what are they? Do you have a plan? Do you have intent? What I recall from Lindsay is she was having thoughts of suicide. She did not disclose a plan, no intent, and her husband was aware of this as well. He was on the call.
And in fact, in any of the times that you met with or had messages with Lindsay Clancy and she talked about intrusive thoughts or suicidal thoughts, did she ever articulate that she ever had a plan?
No.
Or that she ever actually had any intent of completing the act?
No.
And you're aware that she did have support in the way of her husband and her family, didn't you?
I was aware of that.
And again, intrusive thoughts, when a person tells you, a postpartum mom tells you they're having intrusive thoughts in your training experience, in the times that you've treated moms with postpartum depression or anxiety or even psychosis, that's a fairly common complaint, right?
Yes.
And again, depressed and unmotivated, fairly common to hear those from new moms.
Yes.
And in your experience in treating individuals with postpartum psychosis, whether they hear voices or not, did you ever have any concerns based on your contact with Lindsay Clancy that she was suffering from postpartum psychosis?
I did not.
I have nothing further.
Well, it appears as though she was, doesn't it?
Objection.
Hold on. Why don't we do this? Why don't you get over there, Mr. Rankin, if you can, go ahead. Let me ask you a question.
I will try it.
All right. All right. Anything further? All right. Yeah, you can step down. Thank you.
Thank you.
All right. Counsel, could I see you over sidebar? looks like I finally got one prediction about how the day was going to go, pretty close. So we're going to break for the day at this point. And so what I'm going to ask you to do is come back tomorrow at 9 o'clock. The hope would be kind of a similar schedule that we could follow tomorrow as well. And then I'm told that we are well on schedule and perhaps somewhat ahead of schedule. So just for purposes, I don't want to jinx us, but that's kind of where we are. So I'm going to excuse you till tomorrow. Remember those instructions. Don't read anything about this case or any similar cases. Don't do any research. Don't talk about anything. Don't take any field trips. Don't happen to be driving by any certain places. And put this out of your head till tomorrow. All right. It's been a long day. I appreciate it. So I hope you have a nice evening and come back here tomorrow morning. We'll pretty much follow the same type schedule. So again, my thanks. I hope you have a great evening. We'll see you tomorrow.
Court, all rise. Good. Close the notebook, please. Wait.